ഒന്നുമില്ല, ജസ്റ്റ് ഇതിനകത്ത് മഞ്ജും കൂടെ സൂമിനകത്തോട്ട് കയറിയിട്ട് തുടങ്ങുമോ? ഞാൻ ഹോളയില്ല.
ഹലോ ഹലോ
ഹലോ.
Dr. Matthew John, I am going to be in this hall only, 6 o'clock.
No, you are actually in hall B, madam.
I should log into another one, not in this?
No, madam, I think you would have got a different...
I'm getting confused, that's why I'm asking.
No, you have been sent only one link, no? That is for today's link is a different hall and tomorrow's link is another hall for you.
So today I'm not in this hall now?
No, you are in hall B today morning, first stop.
I have to disconnect today. Now and go back there, is
yes,
it?
Yes, yes. You can check your email. That email has got all the details.
Okay.
Chima sir, kekao?
Matthew, good evening. കേൾക്കാമല്ലോ?
കേൾക്കാം, നല്ലതായിട്ട് കേൾക്കാം. ശശികുമാർ സാറിന്റെ മ്യൂട്ടഡ് ആണെന്ന് തോന്നുന്നു.
Now it is okay.
Okay.
സർ കേൾക്കാം. പെർഫെക്റ്റ്.
Right.
Good evening, sir.
തലയുടെ ബാക്കിൽ തന്നെ ലൈറ്റ് വേണം. മാത്യു.
അതെ. ഞാനത് ആക്ച്വലി ലൈറ്റ് വേറെ വരുന്നുണ്ട്. അപ്പൊ ഇച്ചിരി ഒരു സമയം.
ഒന്നാമത് കഷണ്ടി അതിന്റെ പുറകെ
ബ്രൈറ്റും ഭയങ്കര ബ്രൈറ്റ്. ഞാൻ ഓഫ് ചെയ്യാന്ന ഈ ലൈറ്റ്, അതാ നല്ലത്.
ബാക്കിലെ ലൈറ്റ് ഓഫ് ആയി.
ഇവിടെ ബാക്കില് വേറൊരു സ്ക്രീൻ ഉണ്ട്. അപ്പൊ അങ്ങോട്ട് നോക്കിയിരുന്ന കൺഫ്യൂഷൻ ആവുന്നുണ്ട്. ഇങ്ങോട്ട് തിരിഞ്ഞിരിക്കുന്നത് റോങ് സൈഡിലോട്ടായിരിക്കുന്നത്. ഞാൻ മാറ്റാം.
6 മണിക്ക് തന്നെ സ്റ്റാർട്ട് ചെയ്യോ സുനിൽ?
ഗുഡ് ഈവനിങ് സാർ.
ഗുഡ് ഈവനിങ്
സർ. സുഖമാണല്ലോ സാർ?
സുഖം. ഹലോ സാർ. Fine. You are going to be here for 2 days?
Yeah, I'll join. I'll keep on listening to everybody.
എടുക്കാൻ പോയിട്ടുണ്ട്. എന്റെ ബാഗിന് ചാർജർ ഒന്ന് എടുക്കാം. എന്റെ ബാഗ് അവിടെ ഇരിപ്പുണ്ട്, നീല ബാഗ്. Hi Sanjay.
Hi Matthew, how are you?
Doctor.
Fine,
I
Sanjay.
can't see you, Matthew.
I don't starting right.
Okay, fine.
Yeah. You can see me, Sanjay?
Yeah, now I can. All fine?
Yeah, all fine, Sanjay.
Matthew, it will start with an introduction from you, is it?
Yeah, I just, for me, I'll just have a 2-minute introduction to the meeting. Okay, and then I will invite Shashivkumar sir and Sunil Prashod, and Shashivkumar sir will introduce Sanjay.
Yeah.
मैं बढ़िया हूँ बिट्टू, how are you? सब बढ़िया, फर्स्ट क्लास. अपना सुना? सब ठीक चल रहा है. मुझे एक छोटा सा आपसे काम था. हाँ बोल, बड़े वाला बोल. नहीं छोटे वाला ही है. जून में ना मैंने आपको ईमेल भेजा था कॉन्ट्रैक्ट के साथ. वो एक्चुअली हमारे ऑडिटर्स को ना वो कॉन्ट्रैक्ट लगता है आपका साइन किया हुआ. तो तो मैं आपको रीसेंड करूँ, आप साइन करके कल या परसों में भेज सकते हो मेरे को?
मेरे हिसाब से तो मैं भेज चुका था वापस, देखो नहीं भेजा था क्या?
नहीं भेजा था वो।
भेज दो, अभी भेज दो, मैं आज ही कर दूंगा साइन, कल भेज
मैं
दो।
आपको भेज देता हूँ, तो प्रिंट करके आप साइन करके उसका मेरे
हेलो
को
कलराज जी, हेलो
कुछ भेज दोगे तो दैट विल बी फाइन।
चलेगा, ठीक है।
मैं आपको आधे घंटे में
हेलो हेलो सुनील,
कल परसों भी तूने
हेलो
पैसे
शशि कुमार सर, गुड इवनिंग।
Hello.
सॉरी,
कल परसों भी तूने पैसे भेजे हैं।
वो तो आपके मंथली है ना।
ये ऐसे छोटे भाई भगवान सबको देना।
Come on, you are helping us a lot, and in the end, hopefully, we are going to create a lot of value for everyone.
अरे वाह।
Sachuma sir, can you hear me?
Yeah, fine.
Sir, when you introduce Sanjay, no, after you call him for the meeting, just ask him to inaugurate the session also.
ठीक है।
So he will just say, I am inaugurating the meeting. That's it.
मैं करता हूँ।
After the talk.
Okay,
Okay.
bye, bye,
Right,
bye.
right.
Matthew John, I will be joining because I am in the other program.
Okay, sure, no problem.
So as promised.
Yeah. Okay,
Kandra
thank
ji,
you.
good evening.
Or do you want him to inaugurate first and then?
Yeah, I think that is also fine. That is also fine. He
That
can
would be
inaugurate and
that
then.
is better.
Yeah. Up
He
to
will
him.
inaugurate first, then give the CV, and then I will just introduce the topic.
Okay.
Is it okay?
Sanjay, what is convenient for you? This is okay?
मीनाक्षी, अब एक तो जेपी वालों का जवाब देना है।
तो दे दिया।
हाँ, और एक अभी ना 5 मिनट में एक मेल आएगी अरविंदर की या फिटर फ्लाई की, जिसमें कॉन्ट्रैक्ट होगा। वो प्रिंट आउट निकाल लो और साइन करके या तो कल सुबह भेज देंगे। प्रिंट आउट निकाल के रख लेना, मैं रात को साइन कर दूंगा। डॉक्टर साहब को दे देना या नहीं रख देना कागज, या ओपीडी में भी रख देना टेबल पे, तो साइन करके दे दूंगा।
മാത്യു കുറച്ചുകൂടെ റൈറ്റിലോട്ട് ഇരുന്നാൽ മതി, ലൈറ്റ് ബ്ലോക്ക് ആവും. കുറച്ചുകൂടെ റൈറ്റിലോട്ട്.
ഇത് കറക്റ്റ് പ്രശ്നം.
ഇപ്പൊ കുഴപ്പമില്ല. യെസ്,
ഓക്കെ,
ഇത് മതി. ഇറ്റ്സ് ഓക്കെ.
Rajul Das കേക്കാവോ?
Yes.
Rajul Das എത്ര മണിക്കാ പോകേണ്ടതെന്ന് സ്റ്റാർട്ട് ചെയ്യേണ്ടതെന്ന് നമ്മളിപ്പം 4 minutes to 6 ആണ്.
Be muting or when you start, only those who want to speak start unmuting. Okay. Hello.
Yeah. കേട്ടു. We heard you clear. So basically, Rajul will mute. Rajul will mute everyone, and then when you want to speak, please unmute yourself.
That time it will be unshare.
Rajuldas, shall we start?
Yes, I'm going to mute all. Okay, I'm sure.
Okay.
Yeah, you're going to start, right?
Yes.
Yeah, I'm going to remove the share also. Okay.
Good evening to all the national and international delegates for the 5th session of the Diabetes Digital Dialogues. All these years we were going with a physical route, and now we have the digital route of Diabetes Dialogues thanks to the coronavirus epidemic. Since its inception 5 years back, we have tried bringing practical and down-to-earth topics to the practicing physicians. This year is no different. We have brought together various subspecialties onto a stage to discuss good diabetes-related science. This year, we are fortunate to have Dr. Sanjay Kalra, President Endocrine Society of India, to deliver the first talk and to inaugurate the meeting. Most of the time, we name our halls after very famous people, and most of the time the thing belongs to insulin. But this year, we are naming our halls after Professor Roger Unger, the American physician who did seminal work on glucagon, and the second hall will be named after Frederick Sanger, who has done seminal work in protein synthesis and the DNA coding. This meeting is indebted to the sponsors for funding the meeting. So I'd like everyone to encourage them by visiting the stalls, attending the quizzes, and there are many prizes to be won. At this point, I'd like to welcome Dr. Shashikumar and Dr. Sunil Prashob, who are the chairpersons for this session, to take over and take the meeting further. Thank you very much. Dr. Shashikumar. So you can unmute yourself.
Yeah. Good evening, friends. Before we go into the a series of lectures which has been organized today by Providence Endocrine and Diabetes Center, I request the President of Endocrine Society of India, Dr. Sanjay Kalra, to inaugurate the session. Dr. Sanjay Kalra.
Thank you, sir. It's a great pleasure to inaugurate this conference. I wish everyone the best, and we look forward to learning from each other today and tomorrow.
Thank you, sir. Can you put the CV, Dr. Matthew?
Yeah, it's coming. Yeah.
Yes. You can see the enviable academic records and the exhaustive number of publications by Dr. Sanjay Kalra. And to crown all these, he is the current president of Endocrine Society of India. Today, he will talk to you on the topic, is diabetes care going beyond the reach of common man, both patients and diabetes? We have seen in the last 5 or 6 years a number of new drugs coming, GLPs, SGLT2 inhibitors, insulins. All these have a common characteristics, that is cost. They are very, very costly. This is an issue for the patient. And then for doctors, you have to keep yourself abreast with all these drugs, new molecules, the mode of action, pharmacokinetics, drug interactions, so on and so forth. So it is a challenge not only to the patient, it's a challenge to us also. Dr. Sanjay Kalra is a very busy man. I don't know how he manages to keep abreast with all these new things happening. Let's hear his thoughts. Over to Dr. Sanjay Kalra.
Thank you, Dr. Shashikumar. But the answer to your question is that I keep abreast with all the new developments thanks to friends like you and Dr. Matthew John. So that is the advantage, and that is the main aim of CMEs like this, so that we learn from each other. And, you know, maybe our speakers who are going to speak today and tomorrow, they would have spent many days, many hours reading about their topics, and they'll distill that knowledge into 10 or 15 or 20-minute talks for us. So that much time we can spare. And if we are able to do that in an efficient manner, it actually helps us a lot. Let's talk about today's topic, which will set the scene for today and tomorrow. A question to all of us. These are all Indians in front of us in this slide. Which one of them has diabetes? Another question, is any one of them immune to diabetes? The answer is none of them is immune. So diabetes care is something that is reaching, it's at primary level. It's an essential service now. But like our chairperson said, newer drugs are coming, more expensive drugs are coming, and drugs which have very, very, unique kind of pathophysiological basis, unique kinds of pharmacology, they are coming, and it sometimes becomes difficult for the doctor to understand what to give and how to give. So let's talk today about diabetes care, and let's see whether it's actually moving beyond our reach or is it still within our reach. Let me share data from Kerala. From the ICMR INDIAB study, we have a lot of publications. The Kerala data is in the public domain, but it has not been published yet. This is what our state shows. It shows that 24% of all Keralites have diabetes. It also shows that 18% of all Keralites have pre-diabetes. And here they have diagnosed pre-diabetes based upon the WHO criteria, using 110 fasting glucose. They did not take 100 ADA. If they had taken 100, that percentage would have gone up even higher. So what does this mean? 40% of adult Kerala is dysglycemic. This is the common man. So therefore, whatever we plan, we have to plan for the common man. That is 40% of all adult Kerala. Let us look at another thing in this slide. The prevalence of diabetes is more than the prevalence of pre-diabetes. So diabetes is not epidemic anymore to our state. It is endemic now. The people with diabetes will go on with life, and the natural course of life will finally come to an end. They will be replaced by people coming from the pre-diabetes quota. But the pre-diabetes people are not as numerous as the diabetes people. So it is very unlikely that you are going to have a peak of diabetes in Kerala in the future. It has come to stay, and it is going to stay like this. The same way that we are going through a corona plateau. So it's a plateau now in Kerala, and we should stop calling it epidemic. We should start calling it endemic. So our first statement, diabetes is common, diabetes is endemic, and we all know that for epidemics, you have a different public health response, clinical response, but for endemic, you have to have a different response. We are all very fond of using the terminology rule of halves. But when we look at data from across India, we find that a rule of 2/3 predominates in our epidemiology. 2/3 of all people with diabetes are not diagnosed. 2/3, if they are diagnosed, are not treated. 2/3, if they are treated, are not well controlled. 2/3 have complications. And this rule of 2/3 predominates throughout the country. And from the ICMR INDIAB study again, we find that the average HbA1c is 8.2% in Kerala state. This is amongst people who know that they have diabetes. Average duration of 8 years, average HbA1c of 8% plus. So in spite of knowing that they have diabetes, in spite of being from a literate state, a very health aware state, still the A1c is not normal. And the ratio is equally bad in urban and rural populations. We also see from the same study that not many people get insulin. The average prevalence of people getting insulin is something like 21% in urban Kerala, something like 18 to 19% in 17 to 18% in rural part of the state. Total 18%. So we are under treating our patients. Diabetes may be common, but good diabetes care is still uncommon. And in such a situation, we are faced with the challenge of health economics. We all know that diabetes or any chronic disease puts a great burden upon the individual, the family, and the society. But this burden is not only biomedical, it is not only psychological or social, it is also economic. So we have to understand health economics. There are a lot of studies across the country, some big, some large, but let me take this study from Davangere. Why we have chosen this? It is from near Kerala. Secondly, it is a community-based study. Thirdly, it is a very large study. In this study, the authors found out that the average duration of diabetes, known diabetes, was just 4 years. Half of the patients did not have any comorbidity. In the community that they surveyed, the maximum number of patients had a per capita income of 3,500 rupees per month. So it was not a very rich or affluent community that they went to. And in such a poor community with only 3,500 rupees per capita income per month, the average cost per visit to a doctor was 912 rupees. And this cohort had an average of 5 visits per year. So nearly 5,000 rupees every month being spent upon diabetes. And this does not include the time lost per visit. Each visit you would take 2.6 hours going to the doctor, waiting at the doctor and coming back. And health insurance was covered by only, coverage was there for only 2% of this population. When we speak of health insurance, let me talk about another aspect of health economics. And this is how difficult it is for our patients to get health insurance. From this slide, you see that if as a 40-year-old male or as a 60-year-old woman, let us say I go and ask for an insurance coverage. If I do not have diabetes, my premium per month is just 6,000 to 8,000 rupees if I'm 40-year-old, and it's around 20,000 rupees if I'm 60-year-old. But the moment I tell my agent that I have diabetes, then suddenly the premium jumps to double. It becomes around 13,000 or 14,000 for a 40-year-old man, and it goes from 21 to 30,000 for a 60-year-old. So it is difficult for us to convince our people with diabetes to apply for health insurance. When you read the fine print, that is even worse, even more dangerous. In all these insurance coverages, you will see there is no insurance payout if you want preventive foot care. There is no insurance payout if you want a debridement or a dressing for foot injury. But for amputation, they will pay the money. If you want preventive care for a kidney disease, that will not be paid for, but they will happily pay for dialysis and transplant. But they will not pay for a tablet of perindopril or a tablet of sitagliptin or a tablet of empagliflozin. So this is something that is very funny. So because of lack of insurance coverage, certainly good diabetes care is expensive. However, good care of diabetes complications is even more expensive, because the moment we go into complications, macrovascular and microvascular, it is then that the budget begins soaring. So therefore, we propose the law of therapeutic parsimony. Now, parsimony is a very simple English word. It does not mean being stingy. What it means is making appropriate use of whatever resources you have. So we propose the law of therapeutic parsimony and also the law of investigative parsimony, which means that minimal investigations should be done for screening, diagnosis, monitoring, and follow-up, provided that this does not adversely affect patient outcomes. Similarly, minimum drugs, minimum dosage, minimum frequency of dosage should be prescribed, provided that it does not adversely impact patient outcomes. Now, we are all proud Indians, and I personally get very upset when our countrymen and women say that we are resource limited. That hurts me. We are not poor. We may have limitation in some resources, but then we have other strengths, other resources that we can use, and we can use them to our strength, to our benefit. We call this resource husbandry. And this concept has gained mileage, especially during current Corona times, COVID times, because we found that accessibility to healthcare, availability of healthcare, affordability of healthcare, all these were severely impacted, especially in the first 3 to 4 weeks of lockdown. So what does resource husbandry mean? Now, half of all adults, that is all the women, are very good at husbandry because they take care of their husbands very well. For male physicians, sometimes this is difficult to understand, but let's try to understand it. Let's make it simple for ourselves. This is speaking from a male perspective. All resource husbandry tells you to do is to prescribe rationally, whether it's investigations or medication, prescribe rationally. You do not always have to have biochemical or imaging investigations. You have good questionnaires to use. You can use questionnaires to find out the risk of hypoglycemia. You can use questionnaires to find out the risk of cardiovascular disease, of fracture, of other complications. Use those questionnaires because they're free to use. You can use questionnaires to find out about psychological and social health. So use them. Also, you should use some things more frequently. That is our strengths and resources. So reach out to non-governmental organizations near you. Reach out to the government setup if they are willing to help. Ask your colleagues to create self-help groups. Ask your patients to create self-help groups. And you will be pleasantly surprised. Many patients will actually come out and they will say, yes, I want to be an educator. I want to be a leader. Let me help my community. Let me help other people with diabetes do a better job of controlling themselves. We find that in some situations, like for example, in the transgender community, you find that there is a very strong concept of self-help. In orphan diseases, rare diseases also, there is a strong concept of self-help. Self-help is also quite evident in type 1 diabetes. So why should we not encourage type 2 diabetes also, people with type 2 diabetes to do the same? Let's look at other resources that we have. Each person with diabetes has one resource, which is his own or her own body. Why is this slide there in front of us? This is to show that we do not take care of ourselves. This is the percentage of adult Keralites who are physically active. It is 27% in the urban areas and 29 or 30% in the rural areas. 70% of our state men and women are inactive. How can these people complain of medical care being expensive, of diabetes care being expensive, when they are not using the free things that God has given them, which is to exercise, which is just to do physical activity? If they are able to perform physical activity, certainly their medical bills will come down. And this editorial, it is about 8 years old, but it is, at that time, Dr. Unnikrishnan was working in Cochin. So I've brought this up. This is what Dr. Unnikrishnan has to say with us. Why don't we do the things that are economical to do? Resource husbandry means taking full use of our resources. Yoga, meditation, folk dance, martial arts. Kerala is the home of martial arts in the whole world. And Kalaripattu is the mother of all martial arts. It is the oldest martial art form, dance form, or art form in the whole world. Why do we not encourage our boys and girls, our men and women to do this? This does not cost money. So if somebody complains of diabetes care being expensive, that person is mistaken. As a patient, good diabetes care is not beyond my reach, provided that I myself take care of my physical activity, my diet, and then I work a little bit more to take care of my fellow human beings. But what about as a doctor? As a doctor, we always face a dilemma. And this play by Bernard Shaw is more than 100 years old. In this satirical play, Bernard Shaw talks about the doctor's dilemma. Sir Colenso Riggio is the name of the hero in this play. And they talk about how the doctor has to balance between self-benefit, that is earning money, and social benefit or other benefit, which means curing the patient. This is a pleasant play to watch and to read. But what relevance it has for us is, my slides seem to have hung, yeah. What relevance it has for us is that we are answerable to our community. Watching this play will tell you that we all actually go through this dilemma. But you can come out of it if you follow basic ethics, basic morals. And one other person who reminds of these morals and these ethics is Sir Joseph Bore, who in 1946 created the first health report for India. This is what he says, it's in front of us. Only thing is, in today's India, change malnutrition for diabetes, change preventive morbidity for preventable morbidity for preventable cardiovascular morbidity or vascular morbidity due to diabetes. What he says is that the loss is so huge, the human suffering is so huge, the lowering of human efficacy is so huge that the result is so startling. And why should we rest if we cannot improve this? If you look at the public healthcare system, all the drugs are available. Oral drugs like sulfonylureas, like metformin, like insulin are available. And here you can see that even at the primary and secondary care level, the doctor can easily use metformin, sulfonylurea, and insulin, soluble, basal, and premixed, to provide reasonably good care. Some people may need tertiary care, and some people may need referral. So if you have a person who is sick, who has a different type of diabetes, who has a limb threatening or organ threatening complication, or who is not responding to your therapy, feel free to refer to a specialist. But otherwise, the simple drugs can be used easily by any doctor. So therefore, as a patient and as a doctor, good care is certainly not beyond my reach. What I would like to share with all of us is that it is our responsibility to take care of all people with diabetes. 40% of our population is dysglycemic now. Just a little bit of reading about metformin, sulfonylureas, and insulin is enough to take care of 70 or 80% of our patients. We do have newer drugs available. We have DPP-4 inhibitors, SGLT2 inhibitors, GLP-1RA, insulin analogs. I use all of them in my practice. But what I would like to say is, again, when you have a patient with you, understand why you are treating. Are you treating for symptomatic relief? Are you treating for glucometabolic relief? Are you treating the patient for long-term vasculometabolic and viscerometabolic relief? Whatever the patient is asking you for, you try to do a slightly better job than that. Also understand your patient's financial background, how much he can afford, and then you just choose the appropriate therapy. If we are able to follow these simple rules of resource husbandry and therapeutic parsimony, I am very sure diabetes care will be within the reach of all of us. How can we improve our resources? That is by attending this Providence conference today and tomorrow. Our strongest resource is ourselves. So if I spend a few hours this evening and a few hours tomorrow morning, I'm very sure I will be able to strengthen my resource, that is myself. And I'm very sure next week I'll be able to do a better job in my clinic. So I'd like to thank my chairperson, sir, for the liberty of having allowed me a couple of minutes more. And I'd also like to thank the organizers of Providence for giving me this opportunity to improve myself and my own personal resource. Thank you.
Thank you, Dr. Sanjay.
Sanjay, can you stop the screen share? Yeah, it is complete.
We will
Thank you.
take up the questions only at the end of the session. Over to Dr. Sunil Prasad to continue with the next speaker.
Sunil, unmute.
Sunil, unmute.
Okay, first of all, let me extend my sincere thanks to Matthew and Titu for the invitation, and all the best for them for a fantastic CME. We are expecting a fantastic CME. The next topic is going to be headed by Dr. Jyotidev Keshavdev. He doesn't need any introduction. We all know him. He's a very famous diabetologist from our part. He's the chairman of Jyotidev Diabetic Center, Trivandrum, Kochi. He's a very, very famous speaker. And the topic that he is going to deal is the barriers in the adoption of technology in the management of diabetes. We all know of late that there has been several recent advances in the management of diabetes, especially from the technology point of view. And being a practicing physician, we cannot shy away from these newer technologies. We, at some point of time, we will have to adopt to these newer technologies, including the monitoring system, the gadgets. And to talk on this subject, the most ideal person is Dr. Jyotidev Keshavdev sir, because this is a topic very close to his heart. Over to you, sir.
Thank you. Thank you very much. Thank you, Shashikumar sir and Dr. Sunil Prasad. And congratulations to our Matthew John for this virtual CME, very, very successful virtual CME, very impressive topics. Dr. Matthew John has given me this topic, barriers to the use of diabetes technologies. So I have a picture over there, and it is a brick wall. I'll be definitely discussing the barriers, but I will try to find some solutions to break through. So this is a news on e-Sanjeevani platform for telemedicine. And when the e-Sanjeevani or the telemedicine practice guidelines were published by the Medical Council of India, and that was in the March of 2020, which coincided with the lockdown in India, nobody, neither the public nor the doctors, we never thought that this is going to be the rule of the day. We never thought that the public is going to use telemedicine. But look at the numbers. Look at the numbers. a record 3 lakh teleconsultations within a short span of time. COVID is an emergency. And during this COVID pandemic, when we are aware of the fact that more than 1,000 people are dying daily in India, more than 1,000 deaths daily in India, and majority of those deaths attributable to either a new onset hyperglycemia or uncontrolled hyperglycemia and subsequent complications. Even the American Diabetes Association has recommended remote glucose monitoring in those patients critically ill and admitted in the intensive care units with COVID-19. So it's closely linked. Technology is closely linked to not only diabetes, it is also closely linked to the current pandemic. So I am currently also attending, and I am in a panel discussing with an international group a while ago. Why are we hesitant to use even the glucose monitors in India? The SMBG was recommended and endorsed by the American Diabetes Association way back in 1987. Still, not even 2% of our patients with diabetes in India are using this. These are inexpensive, these are cost effective, and the third gen, the glucose meters you see over there, they're connected meters. They are connected via Bluetooth. They have the capability of real-time glucose monitoring. So the moment the patient is checking the glucose values, it is appearing over the web app for the patient, for the physician. And how many of our patients are utilizing these capabilities of transmitting a digital glucose diary over the internet, over the email, or across a WhatsApp? So which are those barriers? Is it the cost, or is it the pain, or is it the expertise that you require for training the patients? The answer, I believe, the answer could be we need to convince ourselves first, because the glucose meters currently are very, very accurate. It is far more accurate when compared to the glucose meters 20 years ago. And many of our colleagues are suspicious about the accuracy. So we need to convince ourselves first to convince our patients. What is the status of the continuous glucose monitoring systems? Remember, it was in 2005, we started using CGMS Gold in our clinics in India, in Kerala. And we have traveled a long way, generating evidences from various publications across the country on its utility in different types of diabetes. And in 2015, with the launch of Libre Pro, the cost was almost reduced by almost more than 50%. And the size of the sensor, as we can see, it is reduced by more than half when compared to the earlier generation sensors. And of course, it is popular in the country. But when you look at the numbers in India, almost 76 to 80 million patients with diabetes in India, the uptake is less. It is very sad that some of these life-saving technologies are not used by even the affordable, even the tech-savvy patients, and not promoted by your colleagues. What could be the reason? And this was delayed in India. It was supposed to be launched 3 years ago, the real-time Libre. It was delayed and delayed and delayed. Every international device manufacturer, they are scared to introduce and launch a technology in India. I don't know the reason. You should be knowing the reasons. The reasons are multiple. And this Libre has been a stupendous success wherever it was launched, wherever in the world it was launched. But in India, they are still skeptical, but they are planning for a launch by the end of this year. Guardian Connect, another technology which has been a huge success everywhere. And this is the only real-time continuous glucose monitoring system currently available in our country. And even the third gen sensor is launched in India. I think it was launched almost 8 months ago. Very, very accurate, and this can be placed over the arm for a lower MARD. Eversense was supposed to be launched 2 years ago. Even I was part of an interview where they were inquiring on the necessity, number one, on the convincing power, and third, they were very much concerned about the cost, because the cost of this, this is only implantable sensor. They have a sense which has a lifespan of more than 6 months. So you may require 2 sensors in 1 year, and the cost will be around 1 to 1.5 lakhs. So the overall cost is going to be far less, but still the upfront cost is high, and hence the uptake is going to be less. And this is now planned with Ascensia in India. I don't know when it is going to happen, probably next year. And this is in the order of MARD, that lower the MARD, higher the accuracy of a CGM sensor. So we have most of these sensors available in India. And there are merits. There are demerits. Of course, a relatively higher cost could be a demerit. But if you look at those barriers, because I am supposed to speak about the barriers of why it is still unpopular among the doctors, among the patients. The number one reason, which I have gathered from my own experiences interacting with the physicians from across the country, criticism by the fellow doctors. I will explain how it happens. You are recommending a therapy. It can be an expensive continuous glucose monitoring system. It can be an inexpensive connected meter. It can be an insulin pump or a 640G. The moment you give an advice or a suggestion, they will try to get an opinion from a nephrologist or a cardiologist or a neurologist or a family physician who is unfortunately not aware of this technology, who is unfortunately not aware of the functionality and on the, within quotations, on the evidence being generated and the recommendations in the clinical practice guidelines. So my humble request will be, as a relatively senior physician, my humble request to all of you will be, if we don't know something, the answer to our patients should be, I don't know, rather than telling them don't use it, because this can be life-saving for them. And the CGM is not meant for numbers. It is more to do with the trend graphs. Of course, the numbers are improving with each gen of the CGM. And if you don't know, or if you are failing with the first 3 or 4 CGMs because of inability to troubleshoot, then never tell them to stop the CGM. The connected pens, the Bluetooth enabled devices, the NFC enabled devices which can connect to the mobile phone app, which can connect to the My Sugar in the mobile phone. And this is soon going to arrive in India from multiple manufacturers. What about the closed loop systems? 640G, when it was launched in India 5 years ago, it was a panacea. Of course, it was it. And it could prevent hypoglycemia up to more than 80% of the time. And in countries where it was launched, such as in Europe or in the US, patients were waiting for months and months and months to collect their device. That was the demand. But in India, again, the uptake was less. What could be the reason? And because of these multiple reasons, 670G, the hybrid closed loop systems were not even launched in the country. This could automatically actually change the basal rates. So the basal rates were automated. And subsequently, we have other insulin pumps as well, where the bolus is getting automated, the artificial pancreas. So the Sono micro pump. Of course, we were also requesting Roche to launch Sono micro pump in India. And this is a device which is tube-free. And it is definitely superior to the Omnipod, which has been popular for more than a decade, but not available in India. Thanks to the requirements, the necessity, there is ACE pumps now available even from the top manufacturers such as T-Slim, the tandem pumps, and from the Medtronic. And these are open pumps. The alternate controller enabled pumps which can communicate with a third-party insulin dosing system, a third-party continuous glucose monitoring system, and so on. So that was a barrier. Remember, that was a barrier. A pump will not communicate with a sensor from another manufacturer, will not communicate with an app from another manufacturer. And this barrier is soon going to be resolved. And there are multiple demerits for the tethered insulin pumps. And believe me, there are multiple demerits for even the so-called patch insulin pumps. However, what is the biggest barrier for initiating or continuing the insulin pump? And this is again the response from our fellow doctors. When we are communicating with our patients on the cost of a device, a cost of a diabetes technology, there is always a phobia for the doctor, the fear of the doctor that the patient will be criticizing on the high cost of therapy. But please understand, it is the fundamental right of any individual in the country to be aware of the guideline directed medical therapy and to choose from the various options. You have to give them the options, because otherwise they will never know that such devices are even available in the country, and they might reject, and could be the reasons of dealing with the alerts and alarms. And the younger patients need not be the ones who are receiving it. They may be tech savvy, but at the same time, the younger patients may be bothered about exposing the devices, attaching the sensor or the CGM, or they may be bothered that the historical data is downloadable, is visible to you. So they want to hide the data. And there are reasons that the younger patients are more fascinated, but the younger parents, they are having a heightened anxiety using these devices. They have low confidence using these devices. They are more bothered about the risk and benefits associated with these devices. And what are the barriers that can prevent adopting these devices? Please remember the fact that in the beginning itself, we have to set the expectations, the realistic expectations. Psycho-education should be an integral component. These devices are unpopular because most of the promising and innovative developments are not accessible to a larger proportion of the patients. And hence, the patients themselves, because of the disappointment in the development of these technologies, the slow pace of development, the slow pace of commercialization, they have themselves started, we are not waiting. They have themselves started developing algorithms, open source algorithms, which has resulted in do-it-yourself artificial pancreas. And this is a recent review from our center, a comprehensive review on do-it-yourself. Another lockdown publication from us on the evolution of insulin delivery devices over the past 100 years. And every new device has been a phenomenal improvement on the existing device. And the broad solutions to break through the barriers will be to include diabetes technologies in the undergraduate and postgraduate curriculum. Diabetes educator is indispensable. And choosing the life-saving technologies, you may have to spend extra time, but that extra time is worth. This is a new normal. And this is going to be the new world. And the new world is going to survive only on technologies. And this ongoing CME by Providence, by Dr. Matthew John, Dr. Tituman and his team, is a perfect example on how we are successfully surviving on these new technologies. And thank you very much, my dear friends, for your encouragement for our free monthly diabetes newsletter. And we have completed 12 years of a newsletter. So thank you so much for your patient hearing, and thank you for the opportunity.
Okay, thank you. Thank you, Joseph, for that excellent talk. Now we will move to the next talk. And the next talk is going to be done by Dr. Nida Deshpande, who is a very famous diabetologist, professor of medicine, bariatric physician from Belgaum. She's a very, very usual face in most of the CMEs in the national conferences. We usually see her. And the topic that she is going to deal is how can we reduce death in patients with diabetes. This is a very, very interesting topic because we all know that ultimately treating complications and preventing death. That is the ultimate aim of most of the treating physicians. So even if you look at any of the drug coming to the market, the most important thing is what is the mortality reduction of that particular drug. So in that way, we are always looking to prevent the complications and death. To talk on this subject, I welcome you, Madam. Neera, Madam.
Thank you. Am I audible?
Yes, yes.
Yeah, thank you, Dr. Sunil, very much for that kind introduction. And thank you, Dr. Matthew, for inviting me for this very well-crafted, beautiful program. All the topics are excellently well thought out. And thank you for giving me this particular topic, which is actually really a very holistic view of diabetes. On the other side, I feel that we don't really, death is a very philosophical and spiritual topic. Actually, we can't really dictate when somebody is going to die. Probably patients live because of us or despite us. I really don't know, but we have to keep trying. With that little, with those little remarks, I shall start sharing my screen. Right. So the topic here is how can we reduce deaths in people with diabetes? If we want to know how to reduce deaths, although we know it, let's just have a look at, I do not have any disclosures. Let's have a look at what is the average life expectancy of a 50-year-old individual with diabetes. Well, there is evidence to say that it is 6 years shorter than it would be without diabetes. So there is a real threat that diabetes can really reduce life expectancy. But can we do something about this? I'm going to talk to you a little later about this, but I can't resist putting this here, that these very 6 years of reduced life expectancy that we talk about, well, you can increase it by 7.9 years. That's what the Steno 2 says at the end of 21 years. So this Steno 2 happened a long time back, but if you look at it now, 21 years later, just a few years ago, it was published that the median survival time was increased by 7.9 years. So what does this mean? This means that death is not inevitable. We can increase survival. We can increase the life expectancy. But before that, what are the main causes of death? Well, this is a slide that is really old, but still holds true today. In 1995, it was that the percentages of deaths with ischemic heart disease and other heart disease were the chunk of the cause of death in type 2 diabetes, as you can see here. Then you can also see here that mortality in people with diabetes, and diabetes is listed as a cause. You can see the third cause in the graph, which means to say that blood sugar itself, which means HbA1c itself can be a cause of death. Then you have cancer, stroke, which again goes into cardiovascular disease, infection, and other causes. Then there are certain other causes which have not been mentioned in this particular slide, and that is CKD. Today we talk a lot about CKD deaths. So that is another thing that we are going to focus on. Then of course you have the acute complications causing death, which actually comes under others. And the last thing which I would like to say is that if there is lack of medication, which is there in our country a lot, you saw a very beautiful lecture by Dr. Sanjay Kalra where he talked about out of pocket expenses, insurance not covering so many things. So lack of medication, lack of medical help in certain areas. So these are all the causes of death. So let's now focus on the scientific causes, that is the cardiovascular disease, etc., and go one by one. In diabetes, we know that you have microvascular disease, macrovascular disease, your UKPDS, DCCT, all these studies showed you that perhaps these two are completely separate entities. That means macrovascular may be completely different from microvascular disease. And traditionally, what have we been taught? Now, this is a paper that was presented at the ADA 2020, where it says that for macrovascular disease, be it coronary syndrome, stroke, or whatever, and also for heart failure with reduced ejection fraction, perhaps life-saving would be statins and antiplatelets. Whereas microvascular disease and also for heart failure with preserved ejection fraction, perhaps HbA1c and tight glucose control is perhaps more important. So these are a few issues which you must remember when you're talking about death in diabetes. So what's the issue number one? Issue number one is HbA1c, and that is diabetes itself. So what has that got to do with mortality, and what has that got to do with cardiovascular disease? So you can see here now that there is a clinical perspective. This is a study which has come out very recently last year. So is it any different actually from the previous? And you can see here, there was a national cohort of US adults, and diabetes was associated with 16% increase in all cause and 18% increase in cardiovascular mortality. And the second point is very important, and that is among those with diabetes, an A1C of 6 to 6.9 was associated with lowest mortality, irrespective of age or prior cardiovascular disease. So statistically, they could delineate that whatever age you are at, whatever is the cardiovascular disease status, if your A1C is between 6 to 6.9%, you had the lowest risk of dying. And diabetes mellitus related excess mortality, which was there, it is lower than in the studies found in the past. So clinically, what does this mean to us? Clinically, this means to us that an A1C of 6 to 6.9 is associated with lowest mortality, and that is something that we should attempt by all means. And this is going to be one of the causes of reduction of death in diabetes. So as you can see here, this is the same thing trying to tell you in the same study. You look at both all-cause mortality and you look at cardiovascular mortality, and you can see that whether there was prior CVD or no prior CVD, as you can see, as the A1C goes above 6.9, the deaths keep on increasing, whether it is all-cause or cardiovascular. So A1C is very important for both all-cause mortality and cardiovascular mortality, and it is not just for microvascular disease. It is also important for all-cause mortality. In the same way, if you look at age, for example, it does not matter whether you are less than 65 or more than 65. Both all-cause mortality and cardiovascular mortality go on increasing as A1C increases above 6.9%. So definitely a good A1C target is going to reduce deaths, as you can see, and this is a very recent paper. The next big issue, of course, is cardiovascular disease. And here we know this is all very well known to you. The stroke risk, the coronary artery diseases, everything is increased in cardiovascular disease in diabetes. So what do we do for that? For that, we have certain drugs. Of course, treating heart disease separately is fine. But the drugs that we use for diabetes, today we have overwhelming evidence. This is a meta-analysis which shows you that the time to first MACE and time to first hospitalization for heart failure, everything is in favor of SGLT2 inhibitors. As you can see, other than the ertugliflozin, all the other have shown you in this forest plot that whether it is EMPA-REG, Canvas program, Declare-TIMI, Credence, all of them show you that SGLT2 inhibitor can prevent cardiovascular death and also heart failure. Again, this is a systematic review and meta-analysis of the same thing, which is very, very new. It has come out in 2020, and this is the forest plot for that, whether it is primary prevention or whether it is secondary prevention, whether it is MACE, cardiovascular death, MI, stroke, CV death, all-cause mortality, almost in all of them. Of course, the overwhelming evidence is for heart failure, but even for the others, you can see that SGLT2 inhibitors can prevent death because they can prevent all-cause mortality and cardiovascular mortality. And you can see in this slide, the hazards ratio are very well depicted. And whatever is, whichever SGLT2 inhibitor you are using, other than, of course, ertugliflozin, as I've already told you, CV deaths are reduced. The hazards ratio are very, very impressive. Heart failure data is very, very impressive. So this is one drug class that can actually help you to reduce deaths in your patient, and it is worth thinking about. Now, this is the second group of drugs which can help us to reduce deaths, and that is GLP-1 receptor agonists. And you can see here that the various studies which are there in all the CVOT trials, many of them are neutral, but you can look at the leader study, the second one from top, and you can see here that it can actually reduce deaths. The relative risk reduction is quite impressive, almost 20%, and the confidence interval is very, very significant in this, as you can see. So the leader study tells us that, and that is why there is a label today for use of these particular drugs. So the newest one that has come, that is oral semaglutide, This also has shown very promising results in cardiovascular outcomes in this particular population. So you can see that composite primary outcome is also very good. It is very good for non-inferiority, and there is a hint for superiority, although it is not statistical, the p-value is not statistically significant. As far as non-fatal stroke is concerned, there's not much, but as far as death from cardiovascular causes, everything is looking, at least it is going towards a trend towards helping patients to overcome cardiovascular disease. Let's come to issue number 3, and that is chronic kidney disease. For the last 20 years, we had ACE and ARB, which we are still using, and which is still very useful in reduction of deaths or progression of chronic kidney disease and end-stage renal disease. But now we have this new class of drugs. After 20 years, we have something that can slow the progression or even prevent kidney disease. And for that, again, you have the SGLT2 inhibitors. And you can see this latest meta-analysis, and it is so much to the left that the renal composite was very, very favorably affected by almost all of them in the same manner. So you have another drug now, which after the ACE-ARB, which helps you to reduce deaths or at least progression of renal disease. And as you can see here, the SGLT2 inhibitors were found to be renoprotective and reduce the composite of worsening of renal function, end-stage kidney disease, or even renal death. So again, death was very much a part of all of this. Credence, the newest one, the best one, because it was meant to look for renal. The others were actually CVOT trials, but this one was particularly so I'm just showing you a prototype, and the eGFR decline. So 60% reduction in yearly loss of eGFR is what you can see here. So this is the latest guideline in 2019 because of the overwhelming evidence of SGLT2 inhibitors and of GLP-1 receptor agonists. It is said that these must be considered if you think that somebody has got CVD risk factors. Now I bring your attention to a very small study called the STENO2, which was multifactorial intervention. Till now I've talked about renal protection, I've talked about cardiac protection, but actually it is not so. It is multifactorial. So it was actually a small study. Participants were randomized in 1993 to intensive. There were just very few patients in this. 4-year follow-up was done for microvascular outcomes. 8-year follow-up was done for macrovascular outcomes, and then the randomization was ended and everybody went into intensive care and the observational part began. And in 2006, that is 13 years from the beginning, they did the outcomes. And then in 2014, post-trial 21-year outcomes. It was a simple single center study. Hardly 160 participants were there with metabolic syndrome, type 2 diabetes and microalbuminuria, as I have mentioned to you. And I'm going to tell you only the 13-year and 21-year data because we are interested in mortality. After 5.5 years of observational follow-up, which means 13 years when it actually started, the primary endpoint of death from any cause occurred in 30% in intensive group compared with 50% in conventional, which was an absolute risk reduction of 20%, which was very significant. And also for CV events, it was 29%. And at 21 years, again, you found the same. And this is my important slide, where the median survival time was increased by 7.9 years. So this is very, very important that simply doing multifactorial intervention, they could find that the median survival time was increased by 8 years. So it is very optimistic that if you fire on all cylinders and look at everything, you can increase survival in type 2 diabetes. And these are the different targets that are used. So you can see here that lifestyle is used, ACE-ARB is used, aspirin is used, then the hyperglycemia is reduced. For dyslipidemia, statins and fibrates are used. Hypertension is looked at. So it's a multi-pronged approach, and that is what we follow today. So the STENO2 diabetes was in that sense a landmark and a seminal study. Issue number 4 is statins. Well, this is the EAS, EASC last year's recommendations. and they say that you must attempt LDL reduction. You have different guidelines here. If they're at very high risk, you reduce 50% from baseline. If they are at high risk and LDL reduction of more than 50% and an LDL goal of less than 70, and you have to intensify it based on your results. And this is the ACC and AHA guidelines. Please look at this. Diabetes mellitus age 40 to 75, you must give moderate intensity statin to all. And if you do the risk assessment in this fashion, then you might have to give intense therapy. But look at this. ASCVD risk enhancers. That means you look at ethnicity, and we are of South Asian ancestry, so it puts us at very high risk. So statins are a must, and you should follow the guidelines. Blood pressure, very important. It should not be forgotten. This is the latest ADA guideline, and you must initiate therapy at the appropriate time, and you must see that the BP is down. Aspirin, well, aspirin is used for primary prevention. You have to discuss with the patient. It is not very sure whether you can use or not, although for secondary prevention, of course, it is used. My last bit is issue number 6, and that is prevention to reversal. If you look at prevention, this is the 22-year follow-up of diabetes prevention study. 75% enrolled patients who were still alive. So you have to lower the risk of early changes in eye disease, kidney disease, and disease endpoints. And this is the famous direct trial which tells you that you can actually reverse diabetes. If you reverse diabetes, of course, you are going to reverse cardiovascular disease also. This is my own data, the impact of very low calorie diet on reversal of metabolic disorders among Indian subjects, a stage definite regression. This was accepted for presentation at the ACE 2020 this year, and this is my own data. So this is my last slide. As you can see here, you have to have multiple targets. If you have multiple targets and you treat to target, definitely you can reduce death and increase lifespan in your type 2 diabetic patients. Thank you.
Thank you, madam. We'll now hand over the mic to Sachikumar sir for introducing the next speaker.
Thank you, Sunil. Next speaker is Dr. Om Lakhani. He represents one of the new genre of brilliant young endocrinologists in our country, techno-savvy endocrinologists in our country. You see his biodata, and I know him essentially for his heroics in telemedicine. He is going to speak to you on a relatively uncommon topic, sarcopenia. Sarcopenia means loss of skeletal muscles. But very often when we see the patient, we don't look at this particular point, honestly. Most of us don't do it, probably because this is not a standardized concept of evaluation. Probably we don't know whether to evaluate in the upper limb, or is it in the lower limb? Is it the muscle mass? Is it the muscle strength? A relatively uncommon area. And Dr. Om Lakhani will tell you all about sarcopenia, how to assess it, how to manage it in type 2 diabetes. Over to Dr. Om Lakhani.
Thank you, sir, for the kind introduction. Are my slides visible?
Yeah, it's okay.
Okay. Thank you so much, Dr. Matthew John, for having me for this event. I think it's a wonderful event. And today I'm going to talk about a very interesting topic, that is sarcopenia in people with diabetes, the risk factors, the assessment, and the prevention. So here you can see 3 people, right? The one on the left, an elderly gentleman. The one in the middle probably, goes to the gym quite often. You can see a photo of the gym in the back. That's the best gym I get, that is mental gym. And the third one you see, who is probably, me, who is probably having sarcopenic obesity. So from here, it's very clear that, the one in the middle is probably the one who is clearly the most healthier. But our patients don't look like this all the time, right? The patients actually look like this. So this is a famous YY paradox by Dr. Yudkin and Dr. Yajnik. And you can see both the people have, both the gentlemen have similar age, similar BMI, yet it's, difficult to say that which of these is having, a sarcopenia, which of these is probably the healthier one. So our patients often look like this. And to me and you, the patient may be the, the fittest person in the room, for me especially, but if you look more carefully, you might be actually sometimes wrong. So what exactly is sarcopenia? And as Sir described to us, sarcopenia is basically two major things. One is the loss of muscle mass, but more importantly, the reduced function of the muscle. So if you see a more formal definition of sarcopenia, and this is given by the European Working Group, they say that if one of the three criteria, that is loss of muscle strength, loss of muscle quantity, or low physical performance, if this is one of the three is there, you should consider sarcopenia. But of course, if all three are there, you should consider a severe form of sarcopenia. So that is basically an operational definition of sarcopenia. So how do you diagnose sarcopenia? How do you make the diagnosis? And there are two things which I want you to take home from this lecture. One is obviously to use your gym more often and probably increase your muscle mass. But the second one, which is more important for a clinician, is to actually diagnose sarcopenia, because we see patients in our clinic and we often we see their blood sugars, we see their vitamin D reports, but we fail to see the clinical side of it, and that is the patient in front of us is sarcopenic, and perhaps we need to assess that problem as well, especially when we are dealing with an elderly population who are prone to these problems. So how do you diagnose sarcopenia? Contrary to belief, it is very simple to diagnose sarcopenia. It just takes 30 seconds to do it. So if you see the European guidelines, they give you a simple mnemonic, that is FACS, that is find the cases, assess them, confirm them, and assess the severity of the cases. So, and this is, if you want to find a case, and when I joined, Dr. Kalra was giving his wonderful deliberation, and he talked about simple screening questionnaires. And, this is a simple screening questionnaire, which is, known as SARCF, which can be used, by an assistant. You can just ask an assistant to fill it up when the patient is waiting in the waiting room. And then here you can see, a simple score of 4 or greater is predictive of sarcopenia. And here we look at the strength, assistance in walking, rise from the chair, climb stairs, and falls. And you just, all you need to do is, you need to just assess the patient, ask them a few questions. And this is a simple screening questionnaire for diagnosis for finding the cases of sarcopenia. To assess for sarcopenia, again, not very difficult. You can use two simple things. One is chair strength test, another is known as a grip strength. A chair strength test is very simple to perform. I'll just show you the quick slide of it. You take a timer. We all have a digital timer these days. You don't need to see this. So all you do is put a 30-second timer and ask the patient to stand up and down on a chair as quickly as possible, as frequently as they can. Right. So it's a simple test. The patient has to use. All the patient has to do is to use their lower body strength to get up and get down. Like I said, it takes just 30 seconds to make the diagnosis. The cutoff for this is 12. So if you can, and try doing this, if you're sitting there listening to this lecture, try doing this in 30 seconds. And, at the end of the lecture, put it in the chat or tell me how many times you could stand, or whether you suffer from sarcopenia or not. And, the cutoff is, you can see the cutoffs depend on the age, of course, but, generally speaking, less than 12 is considered to be abnormal, right? In a typically median score would be less, if it's less than 12, you should consider that to be abnormal. So again, like I said, if you're sitting in the chair, get up, do it, and tell me how much it is. You can use slightly more, sort of a equipment if you want. This is a JAMA dynamometer. These are available on Amazon. You can buy it. It's not very costly. This tests the grip strength. You can use it especially for if you're trying to understand, do clinical studies on sarcopenia. This is a very useful device. And this is known as Camry's dynamometer. Often a digital dynamometer, you will be able to, purchase this very, cheap devices, cost less than $1,000 easily on Amazon. And you can use this very easily. It takes, again, 20 seconds to really make the assessment. So a grip strength typically is considered less than 28 kgs for men is considered to be low, and less than 18 kgs for women. So when you say kg, this is what the values which will be displayed in this dynamometers. And if it's less than 28 for men and less than 18 for women, it is generally considered to be on the lower side. Okay. How do you confirm sarcopenia? Again, if you've gone and done so much, I think you've done great. if you're just screened for them, and if you're really, done the chair strength test, I think that is more than enough. But if you want to go a little deeper and really want to look at the patient in more detail, you can do a confirmation of the same by checking the, detection of the low muscle quantity and quality. For this, of course, the standard and the gold standard is a DEXA scan. So if you're sending your patient for a BMD, for bone mineral density using DEXA, you can also ask your DEXA technician. It's a simple software. It doesn't require anything very fancy. You can use the same for body composition analysis also. You can, of course, use CT scan or MRI for research purposes. A very simple thing to do is, this is done by oncologists, that if you're doing CT abdomen, try to look at the muscle mass at L4 level. This is a kind of a standard. You can check a lot of studies on that done on this, and the muscle mass at that level is considered to be a simple detector of that. So like, you don't need a special CT just for this. You can use one of the CT scans done recently for this. Of course, you have bioimpedance devices which are very popular, used by a lot of gym people, but it is not advised to use it in general because it is not very, very accurate. But I think DEXA is something very simple. So if you're using DEXA, of course, you need something for body composition analysis. This is a report generated from Hologic, and you can see it will give you the lean mass, which is the one mentioned here. The total lean mass in this patient is 59 kgs. Now, of course, it's simple to understand the fact that a person who is larger in size will have more lean mass. But so what you do is you need to take the lean mass and divide by height square. Right, so you need to take the lean mass, which is derived from the DEXA, and divided by height square. And in Asians, this is what is important to us. Sarcopenia is defined when this value is less than 7 kg per meter square in men and 5.4 kg per meter square in women. So it's a very simple thing to do. Again, not very complicated. Like I said, if you're treating osteoporosis routinely and you're sending your patients for a DEXA BMD, also ask them to measure the body composition also. And severity can be done, checked very simply by doing a simple gait speed, choose a distance of 6 meters and calculate this velocity of the patient. And, if it's less than 1 meters per second, you have, a highly severe, and like, if you're smart enough and if you're like Sherlock Holmes, as soon as the patient walks in, you can probably say, look, this guy has sarcopenia. The slow gait speed is one of the markers of, not only it's a marker of sarcopenia, it's a marker of severe sarcopenia. So just keep your eyes and ears open for your patient. So just to summarize the diagnostic part of it, this is the current definition of sarcopenia, based on the various guidelines you can see here. And I'll not go into details because I already discussed this, but you can of course look this up, and you can probably take a screenshot of this and save it and paste it on your clinic for making a quick diagnosis. So what are the risk factors for sarcopenia? Why does sarcopenia develop? Of course, age is the biggest risk factor, vitamin D deficiency, obesity, and I'll talk about this in a few minutes, diabetes, deficiency of sex steroids, other endocrine disorders like thyrotoxicosis, Cushing's, malnutrition, very common in India, certain medications, and neurodegenerative disorders. So then let's come to the concept of sarcopenia and obesity. So what exactly is sarcopenic obesity? Now, there is no formal definition for sarcopenic obesity. It is basically low muscle mass with increased fat mass. So again, a simple way of testing this is looking at your DEXA body composition report. Now, the important point here is that sarcopenia and obesity have a bidirectional link. So sarcopenia leads to obesity, obesity leads to sarcopenia. Again, I'll not go into too much details of it, but remember, obesity is a form of sort of a mild pro-inflammatory state. And this pro-inflammatory state leads to depletion of the skeletal muscle, leading to a sort of a bidirectional link. And reduced skeletal muscle, again, reduces the overall function, increases insulin resistance, and often worsens the obesity. So like I said, there is a bidirectional link between obesity and sarcopenia. Again, looking at sarcopenia and diabetes mellitus, right? So basically, sarcopenia, what sarcopenia does is it produces peripheral insulin resistance. Remember, muscle mass is responsible for your glucose disposal. That is diabetes 101. So in absence of muscle mass, the glucose disposal is naturally reduced. It is simple to understand, and this leads to peripheral insulin resistance, which may of course lead to diabetes. And recently we had Dr. V. Mohan publish the various cohorts of patient or various clusters of patient with diabetes, where he talked about mild diabetes in elderly, and which is one of the cohort or one of the cluster. And I think a lot of the times the cluster in Indian patients is simply because of sarcopenia. It's just sarcopenia that leads to a simple mild form of diabetes mellitus. How does diabetes itself cause sarcopenia? Diabetes again is a state of low-grade inflammation. There is reduced physical performance, and of course, certain medications that we use may have an impact on causing sarcopenia. Now, as far as the medicines are concerned, there are two of them which are likely to produce sarcopenia. One is metformin, and the other one is SGLT2 inhibitors. We'll discuss SGLT2 in a minute here. But insulin, remember, and perhaps sulfonylurea, we're not very clear about it, but insulin definitely increases the muscle mass. You know that insulin is anabolic in nature, and it increases the muscle mass, and hence, it has a positive impact as far as sarcopenia is concerned. So, you have a poor controlled diabetic with sarcopenic obesity. Giving insulin may cause weight gain, but there is also increase in muscle mass, which is the interesting aspect of using insulin. Again, you can see from this table, most of the things, we are not very clear because there are not many studies done in medications, impact of medications on sarcopenia. And I think, if you're young doctors listening to this, please, I request you, this is an area of research which you should strongly consider, because, we have an aging population and Indians are often having sarcopenia already. And I think using the right anti-diabetic medication for these population may be very, very useful. And I think this is a study which must be carried out. It's a very simple study and can be done very easily. Talking about SGLT2 inhibitors, and this is one of the criticism. Now, SGLT2 inhibitors, as you heard from Dr. Neeta Deshpande's talk, a wonderful talk, she said SGLT2 inhibitors increase the survival of the patient, and this is no doubt about it. But one of the criticisms of SGLT2, especially from our patients, is that they often lose significant amount of weight, and they also develop sarcopenia. Now, it's easy to understand why sarcopenia develops with SGLT2. Of course, there is a low insulin, high glucagon, which increases protein breakdown, and of course leads to sarcopenia. This is taken from a case report. Very interesting to see here. This is a patient, elderly patient, who was given SGLT2 inhibitor, a diabetic patient. You can see the fat changes in the fat and the body composition here, and you can see the subcutaneous fat significantly reduced on day one. The visceral fat significantly reduced, in a few days, and you can see the muscle mass. I think this is day one of evaluation, actually, not day one of the thing. Patient was on treatment for a while, and the sarcopenia, there was also reduction in the muscle mass. So SGLT2 does lead to reduction in muscle mass. However, it also leads to reduction in the subcutaneous and visceral fat. So I think it has sort of a multi-pronged effect. When SGLT2 inhibitor was stopped, of course, there was a restoration of a lot of things, including the muscle mass. So, the criticism is perhaps not wrong that SGLT2 inhibitor lead to reduction of muscle mass. Now, SGLT2 inhibitors reduce fat more than muscles. So overall, if you see a sarcopenic obese patient, the patient may actually benefit because the fat reduces and the muscle mass often also reduces, but the fat increases, it reduces more. So it's like, the classical debate of glass half full or half empty. The patient choice is, of course, very important. So how do you manage sarcopenia? Diet, exercise, vitamin D. These are the three main pillars. The diet, of course, you need to increase the protein content of the diet. And studies have shown that a protein intake of 1.2 to 1.6 gram per kg per day, that is a recommended daily intake, leads to improvement in the muscle mass. However, increasing it beyond 1.6 grams per kg does not lead to further increase in the lean mass. So this is, your standard protein intake, which is, of course, Indian patients don't take this much also, often leads to improvement. If you want to see the exercise, aerobic and anaerobic. Again, if you can see my virtual background, gym, right? Even your elderly patients need to go to the gym and increase their muscle mass. It's not just, just aerobic exercises. You have to do both. You have to do strength training also. Of course, make sure that your patient is not injured. Vitamin D intake, there is a interesting link between the bone and the muscle, and vitamin D has been, of all criticisms of vitamin D, I think this is one which I think probably is something which is a valid point. I think vitamin D does lead to increase of bones, increase of the muscle strength, and of course that should be considered in your vitamin D deficient patient. Vitamin D can be helpful to some extent. Of course, hormone replacement can always be considered, estrogen in women and testosterone in men. But this is an area of a lot of controversy and debate, and I think this controversy can be solved at a later date. So I'm not going to touch this. But of course, theoretically, hormone replacement definitely improves the outcome. You have selective androgen receptor modulators or selective estrogen receptor modulators, which can have a positive impact, and perhaps changing diabetic medications, may have some impact, especially in certain group of patients. So just to summarize some important take-home messages, the first and important take-home message is to diagnose sarcopenia. Like I said, it takes 30 seconds to do it. So please do it. It's very simple to do it. Just note it down in your prescription or in your letterhead. It's very simple in your notes. At least the patient understands this. At least you understand this, that you have done it. And I think this is a simple exercise to do. The other exercise that, of course, you need to do is to go to the gym. I'm saying this again and again. First, you find the cases, assess them, confirm them, and check for the severity. The second important take-home message is that sarcopenia and obesity have a bidirectional link. Sarcopenia leads to obesity, obesity leads to sarcopenia, and of course, similar bidirectional link with diabetes mellitus itself. The third important take-home message is that you need to understand that there are potential risk factors for sarcopenia. You need to look for them and correct them, and look closely, perhaps, at the role of SGLT2 inhibitor in relation to sarcopenia. Perhaps, like I said, this could be an important research question. And finally, proteins, vitamin D, and some amount of resistance training are important for treating sarcopenia. So I thank you again, and do a little bit of resistance training to your daily exercise routine, and you will be really well off. Thank you.
Thank you, Dr. Wong. It was really fabulous to hear about a new aspect of diabetes care. Do we have time to take a few questions, Dr. Matthew? If there are any questions?
Yes, we can take a few questions.
Okay. Is there any question in the chat box or?
Yeah, we can take a few questions.
There is one question to Dr. Jodev sir. Jodev sir?
Yeah, I am here.
So there is a question, sir. Sir, do you think adoption of technology is more of a doctor's problem than a patient issue?
It's a good question because we are having a technology program now, and there again we were discussing this all over the world. It is more of a doctor's issue because if you look at the technologies such as insulin pumps were there for more than 45 years. And even the glucose meters, the ones which has been endorsed by the American Diabetes Association in 1987, still the uptake is only 2% in India. So these are some of those technologies which can change the lives of individuals with patients with diabetes, which can bring better short-term and long-term outcomes, but still probably not promoted by the doctors. And the reason could be, number one, the doctors are not convinced. Number two, many of them are practicing without a diabetes educator. And if you look at some of the newer glucose sensors, even without doctors promoting it, the patients themselves are purchasing it. And their purchase is more from the patients rather than from the promotion done by the doctors. So collectively, we should take a decision during this COVID-19. The technologies are the ones which will ultimately help all of us survive. So that should be the take-home message.
Thank you, sir. Thank you, sir.
Any other question?
And one more, Nida, madam. Madam, in one of your slides, a very common slide, we see the most important cause is the cardiovascular cause among the death, then renal, and infections come rather late in the stage. Now, in this the present context, the COVID pandemic, after the COVID pandemic is going to end, where do you think the position of infections will be in that?
Infections have always been there, and they will always be there. As I showed in one of the slides, if you look at the proportions, infections come almost as a cause of death, almost 1/4 that of cardiovascular causes. So infections are always there, especially in badly controlled patients. And we always have to be on the lookout. And then the flu shots, the vaccines, and the care that has to be taken when they have urinary tract infections. So that will always be there. And with the new pandemic that has come in, perhaps respiratory tract infections are going to be more. I mean, we still don't have evidence that diabetics are more prone to getting the coronavirus, but we know that they get it. It becomes very severe if they do happen to get it. So infection, the status has remained same over the decades as far as diabetes is concerned as a cause of morbidity and mortality.
Thank you, madam. Shashi Kumar, sir.
Dr. Wong.
Yes, sir.
When you use SGLT inhibitors, they say that there is 2/3 weight loss of adipose tissue and 1/3 by the skeletal muscles. What causes the loss of skeletal muscle?
Yes, sir.
What's the cause for sarcopenia when we use SGLT inhibitors?
Yes, sir. So, as we had, seen in the slide, basically what, SGLT2 inhibitor does is that it sort of causes a reversal of your normal metabolic milieu, leading to more proteolysis. So, you have, it creates a state of for the body to think of it as a nutritional deprivation. And in that scenario, what the body does is it activates sirtuins, it activates, increases the glucagon, increases, so in such a scenario, glucagon causes, and all this creates a scenario where the muscle is broken down in preference to, proteins which are important for survival, So in that sense, what happens is that basically it induces a state of proteolysis because of the increased glucagon and increased sirtuins, and I think that that is what ultimately leads to protein breakdown, leading to sarcopenia.
But there is only a carbohydrate deprivation. There is no protein deprivation.
Sir, what it does is that, sir, there are certain nutrient sensors like sirtuins, AMP kinase, and all that. These sensors sort of give signals saying that body is in the state of nutritional deprivation. So when you have and these are also reasons why it has it has a sort of a protective effect also. So what it does is that when you have a SGLT2 inhibitor given and you have a drop in the the glucose are flushed out, the sirtuins are activated, which gives a signal of a state of nutritional deprivation, and that increases the glucagon, that increases the various other sort of a counter-regulatory hormones, leading to the protein breakdown. And interestingly, what is interesting is that Indian patients, and if you see, of course, there are no clinical studies to say, but there was a study done from the Medanta group which have shown that one of the common symptoms which often patients complain about is actually the loss of muscle mass. The patient often feels that their muscle mass is lost, they feel tired, they feel fatigued, and I think this is a clinical feature which is seen. I think this is an area of research. I think we should be looking at this more closely. Perhaps we have lesser muscle mass to start with, and that is one of the reasons why we probably lose also a little bit more. I think, but I think at end result is a positive. I would say I would still encourage use of SGLT2, because of these various benefits that you get. And I think but this is one aspect we should really look at, and perhaps give some protein supplementation to our patients, as a preemptive to help them out.
You mean to say that we should be careful in using SGLT2 inhibitors in lean elderly patients?
Yes. So I think that's the group of patients who, again, we should, any drug has a sort of a risk benefit ratio that we must consider. And an elderly gentleman or elderly lady who is already sarcopenic, I think in that group of patients, we should be really looking at assessing whether, giving SGLT2 really gives you a benefit in terms of the risk which you get from sarcopenia. Of course, there are not many studies. Whatever I could find were a few case reports which show, objectively that this happens. But in terms of subjective assessment, I think a lot of patients do have that muscle mass which is lost, which we do definitely see in practice.
Thank you, Dr. Ram. Any other question from audience? Can I ask one question to Dr. Neeta?
Yes, sure.
You have looked at microvascular complications and macrovascular complications as two entities.
Yes.
In fact, you look at the pathobiology, it is basically both micro and the macrovascular complications operate through increased production of ROS. It may be in a small vessel or it may be in a large vessel.
Yeah.
Do you think from the etiological point of view, there is any significant difference between microvascular complications and macrovascular complications?
There does seem to be a distinct difference, because if you look at the Wikipedia study, and the reason for that I will tell you, the reason for this is that you cannot really time when the macrovascular disease has started in a type 2 diabetic. It could have even started way before the type 2 diabetes was actually detected. Whereas it is very well known that microvascular complications are a function of the glucose level, whereas macrovascular complications are a function of all the other things, all the other risk factors such as blood pressure, lipids, etc. So the microvascular disease that is there, that is seen mostly, there are very few exceptions, but they are mostly seen after the onset of hyperglycemia, whereas it can be preceded in the case of macrovascular. And that's why they thought of, and if you look at the UKpedia study also, you can find that the tight glycemic control very favorably affected the microvascular complications, whereas it was statistically not significant as far as the macrovascular disease was concerned, where that is why it came out that there could be two distinct entities. They are vascular only, and atherosclerosis ultimately does affect the smaller vessels also. I don't deny that. But the trajectory of events that happens where the macro and microvascular complications are concerned, they're quite different, especially when you give intensive.
No, what I mean to say is the basic denominator in both micro and microvascular complications is increased ROS production.
Correct.
So this
I agree. I agree with that. It is perhaps the timelines that are important. And if you look at the determinants of these complications, and if you look at the outcomes of intensive control, the outcomes are quite different. So that makes us feel that for macrovascular disease, what you require is a multi-pronged approach, whereas for microvascular disease, it appears as if A1C reduction is of prime importance. So that is what all the data shows.
Thank you, Dr. Nita. If there are any more questions? If there are no more questions, shall we wind up the session? Dr. Matthew?
Yes, sir. I think we are just across a bit of time, but that's okay. And I really thank the chairpersons and all the speakers who have taken out their time and came to this meeting, the Diabetes Digital Dialogues 2020. And now we will move forward to the next session, that is critical questions in diabetes. And to chair this session, we have two young, dynamic physicians who are interested in diabetes practice in from Kerala. Dr. Prashant Shankar from Pathanamthitta, who is also interested in patient-oriented social media teaching, and who is very keen in that aspect also. And together with Prashant for chairing the session, we have Dr. Sugesh, who is, in addition to being a physician interested in diabetes practice, is also a multifaceted personality. He is a poet, he is a writer, he is regularly in lockdown days, he is spending his days authoring short films and writing and publishing his own book of poetry. So I welcome Dr. Prashant and Dr. Sugesh to take forward the session.
Thank you, Dr. Titu. Hope I am audible to you. And welcome, Dr. Sugesh also. Thank you, Matthew John, sir, for providing this wonderful opportunity at this excellent symposium. So without wasting much of time, we will go into the session. So the first speaker for the day is Dr. Tejas Shah. Can I have his profile, please? Yes. Yeah, Dr. Tejas is the honorary diabetologist at SL Raheja Fortis Hospital, and he runs diabetes care centers in Mumbai. He is also the visiting teaching faculty for Fellowship of Diabetology at Dr. D.Y. Patil Medical College. He is the founder and treasurer of United Diabetes Forum and organizes Challenges in Diabetes, which is one of the largest scientific conference. It is a well-organized scientific conferences in the country. And he'll be talking about home BP monitoring, how to tell patients to monitor the BP. So it's becoming a more and more important thing nowadays, especially because the patients are not able to come to the clinics routinely. Most of the patients have a BP monitoring at home. And to add to that, we have this problem of mental stress and distress, which is there during the COVID, which knowingly or unknowingly increases the BP level. So every day we have patients calling up after monitoring their blood pressure, telling that the BP has shoot up considerably, should we increase the dose of drugs, decrease the dose of drugs. So there are certain basic things to be kept in mind while the patient monitors the BP, the method, the technique to be used, the measurement, the apparatus to be used, and the timing of BP measurement. So I hand over the session to Dr. Tejas to enlighten us on this important topic.
Thank you. Thank you, Dr. Prashant. Hello. Yeah. I hope my slides are seen.
Yes, Dr. Tejas, your slides are visible.
Okay. Thank you, Dr. Matthew. Thank you to the entire organizing team of Digital Diabetes Dialogues, and it's a wonderful event. And thank you for giving me this opportunity here today. It's an interesting topic because as I went through the topic, I also got to know many important facts about the topic which we have been missing in our routine clinical practice. So we all know the importance of hypertension. We know that hypertension is the leading cause for cardiovascular disease over a period, and it is the most preventable risk factor, as we know, for various diseases like stroke, for chronic kidney disease, for heart failure, and for cardiovascular disease. In spite of all the evidences, as we know, for hypertension and the importance of hypertension control, there are actually very, very few trials which have spoken or which have discussed the importance of home blood pressure monitoring, the importance, the correct methods of monitoring, the impact of the correct method of monitoring that it has on the results, and the importance of home blood pressure monitoring on morbidity and mortality. So accurate blood pressure measurement is an important aspect of hypertension management. And as Dr. Prashant rightly said, in today's times of the pandemic, when patients are not able to come to the clinic, patients are not able to, and we are doing more of teleconsultations also going on, I think home blood pressure monitoring becomes an important tool for us to assess our patients' control. So for years, we've been talking about blood pressure monitoring as something like which we always associated with an office or clinic blood pressure monitoring. Traditionally, we've been doing it for years with the mercury sphygmomanometer, which got banned a few years back. And we also are using the aneroid sphygmomanometer in our clinical practice. And also there is an automated system that can be used in the office or clinic blood pressure. There are some disadvantages that clinical trials have shown with the office or clinic blood pressure measurement. There have been some fluctuations in the values. There have been which is dependent also on the operator. There have been factors like the white coat hypertension or the mask hypertension, which plays a role and which does not give the correct office blood pressure measurement sometimes. So the other aspect of BP measurement is the out-of-office blood pressure measurement, and that is the home blood pressure monitoring system or the ambulatory blood pressure monitoring system. The ABPM, as we know, is the gold standard or considered to be the gold standard for blood pressure measurement, where a person wears the device for 24 hours and the blood pressure measurements are recorded. It has its own advantages where it definitely gives a more wider range of measurements. Nocturnal blood pressure measurements, which are usually missed by the other methods, can be recorded in the ABPM, especially the nocturnal dips that occur in a person can be recorded with the ABPM. But again, it's a bit of an expensive affair. Patients cannot keep that at home or do it on their own. And per se, it is something which is a hurdle to do in everyday routine practice. The other aspect of out-of-office measurement is the home blood pressure monitoring system, which is what we are going to talk about today. It has been recognized and it has been used for a number of years. Various methods have been used for home blood pressure monitoring systems, various devices which lie basically on oscillatory or the auscultatory or the tonometry system, where the oscillatory system is considered to be the most accurate. We know the current guidelines of hypertension, what mentions the ideal blood pressure. Of course, there is a slight difference between the American College of Cardiology and the AHA versus the European associations, where more than 138/80 is considered to be hypertensive, while more than 114/90 is considered by the European Association. The targets for treatment also differ, with less than 130/80 by the American College, while systolic target of less than 140 and close to 130 is what the European mentions for BP targets for treatment. And then hypertensive requiring intervention would be more than 130/80 by the AHA and by more than 180/90 by the European Association. If you look at the limitations for the office BP measurements, mainly that the smaller number of readings are typically taken in the doctor's office. It is only once in a while when the patient comes to your clinic that you are able to record that. Sometimes poor technique, rapid cuff deflation, improper cuff, not a proper quality of the machine are often there, or sometimes it is the paramedical staff who is doing that and not the trained personnel very well doing it in a clinical office. White coat hypertension is one of the important aspects for office BP measurement, where a higher blood pressure in the clinic setting, while a normal blood pressure at home is normotensive by ambulatory measurement is what is seen. And sometimes it's the reverse, where the mask effect, as we know, that the patient is normotensive by clinic measurement and hypertensive by ambulatory measurement, which may lead to under treatment per se. At the same time, if you look at the out-of-office BP monitoring or the home monitoring, it provides a larger number of BP measurements away from the medical environment. A person can check more number of readings in a more relaxed environment where the patient is at home or in his place of comfort. Out-of-office monitoring comprises mainly, again, two techniques as I showed you earlier, ABPM as well as HBPM. So self-monitoring of BP at home and work is per se a more practical approach to assess the difference between office and out-of-office BP measurement. And for those whose out-of-office BP measurements are less than 130/80 consistently, despite having an increase or elevated blood pressure in your office, but who do not have evidence of target organ disease or risk factors, maybe a drug therapy can be avoided if the patient monitors their BP per se regularly at home and gets a reading of less than 130/80 persistently. Various guidelines like the Hypertension Canada guidelines, the NICE guidelines, the European Society of Hypertension, the American College of Cardiology have all endorsed and recommended HBPM as the standard now per se, or can be considered equivalent to the office BP measurement, and has been endorsed by them. A growing body of evidence per se supports the benefits of HBPM compared with office-based monitoring systems. There have been clinical trials, though lesser numbers, which have correlated the HBPM with increased or higher HBPM with increased morbidity and mortality. Further, if you look at the economic aspect also, the home blood pressure monitoring is per se cheaper and easier to perform than the ABPM, and per se all digital or automatic devices which do require validation, and per se these validated devices are the ones which have been recommended for home monitoring. What are the ideal indications or for which HBPM should be encouraged per se? Diagnosis of course, possible hypertension, treatment of hypertension, both can be done with the help of home monitoring. Management and monitoring of patients which are difficult to treat or resistant hypertensions, patients who may be on 1 or 2 drugs or more than 2 drugs already, and in spite of which you may have different changes in blood pressure or elevated blood pressures, can be advised to monitor their BP more frequently, and the dose titration can be done itself more easily and without calling the patient to the clinic also very frequently. High-risk patients, especially diabetic patients, patients with chronic kidney disease and pregnancy, in whom a closer monitoring of blood pressure is required, are the ideal candidates where home blood pressure monitoring should be encouraged. And an ideal tool to monitor and follow up patients with pre-hypertension or higher normal blood pressure, especially a patient whose blood pressure is detected at a higher level in your clinic for the first time. It may be due to white coat, it may be due to the anxiety aspect. These are the patients where home blood pressure monitoring might be more useful to diagnose hypertension and to decide whether they require a therapy or not. Again, it is an important aspect to identify white coat and mask hypertension. Home monitoring per se has shown good reproducibility, is well tolerated, and per se is inexpensive. It is again a complementary method to ABPM, but it is a much more easier method to be done, and per se superior method to blood pressure taken in the clinic per se in preventing cardiovascular events and mortality. So when you teach a patient to do HBPM, certain aspects are something which are important. Ideally, tell the patient to do it in a sitting position. The back needs to be straight and supported. He should be ideally be sitting in a chair at home with his hands laid on the table, arms bare and supported. Using a cuff size which is appropriate for arm is the most important aspect to get a correct reading for HBPM. An inappropriate cuff results in a wrong reading. A cuff which is undersized usually gives an overestimation of the reading, or a cuff which is much larger in size gives invariably a lower reading, and therefore the size of the cuff is the most important aspect for to be taken into consideration. The cuff should ideally cover around 80 to 100% of the mid-arm circumference. The middle of the cuff should be at the heart level. The lower edge of the cuff should be 3 centimeters above the elbow crease. Patients should be instructed not to do not talk or move before or during the measurements. The legs should be straight and feet should be flat on the floor. Twice daily measurements are usually recommended in the morning and evening for a minimum of 5 days when the patient starts monitoring at home. The threshold for defining hypertension is an average home blood pressure monitoring of 130/85 or above. Patients are engaged with their management when they monitor their own blood pressure, and hence usually we see an increased adherence to therapy and a better reduction in blood pressure. Finger and wrist devices should be avoided as they are not accurate, and that has been seen in various trials again. There are certain patients who may not be ideally be suitable for home blood pressure monitoring. Some patients with undue anxiety in response to high blood pressure readings, physical or mental disability prevents accurate technique or recording. Patients who may not be able to do this technique easily at home. Arms which are not suited for blood pressure cuff. Example, sometimes some disorder morbidities are there or deformities are there in the arm. Irregular pulse or arrhythmias prevent accurate readings, especially patients with an arrhythmia disorders. The oscillatory meters may have an error in the readings when they have an arrhythmias. And of course, lack of interest and lack of adherence would be one of the issues for these patients. When we are talking about home blood pressure monitoring, if we look at the advantages, of course, they can take multiple readings over an extended period of time. You can avoid the white coat reaction to BP measurement. They are more easily reproducible, the readings. The patient can keep on taking the readings more frequently and thereby predict, or we can have a more clarity on the results that are there. It predicts CV morbidity and mortality better than office BP readings. There are some trials which have shown that. Can diagnose both white coat as well as mask hypertension. It allows patients for better hypertension management. It can be easily accessed to tele-monitoring and tele-video consultations that we are all used to doing now in the last 5 months, where you can assess the patient's record of blood pressure much better and thereby detects more increased BP variability. There are some limitations which we have to keep in mind. There are some devices which may not be very accurate out of all which are available to us. Cuff placement, as I told you, is a very important aspect and can have an effect on the accuracy if the cuff is not placed properly. It may induce anxiety and excessive monitoring sometimes to certain subset of patients. Risk of treatment change by patients based on casual home measurements without doctor guidance could be there. Self-treatment is known in our patients, and sometimes they may skip the medication seeing a normal blood pressure, or sometimes they may take an extra dose seeing a higher blood pressure. Lack of nocturnal monitoring is again one aspect which is there only with ABPM. And of course, it's not something which is reimbursed by insurance companies in many countries, though the devices are not very expensive also. When we are talking about recommendations for home blood pressure monitoring, the NICE guidelines have laid down certain criteria for monitoring. As I told you earlier, for each BP recording, 2 consecutive measurements need to be taken at least 1 minute apart with the person. BP recorded twice daily, ideally morning and evening, and that 2 readings each time. BP recording should be done for at least 4 to 7 days. Discard the measurements of day 1, where the average value of remaining days can be used or should be used as the average blood pressure readings. The first day readings need to be discarded. Monitors that use the oscillometric methods are the reliable ones and easy to use. The European Society of Hypertension recommends a semi-automated cuff or an automated electronic devices that measure BP at the upper arm, and monitors equipped with automated memory can prevent sometimes the misreporting, and the finger and wrist devices are not recommended. If you look at the compliance aspect, it has been seen that for patients who have been using HBPM, the compliance and adherence has always been better. They are found to have a significant reduction in systolic and diastolic blood pressure. Reduction in antihypertensive medications and therapeutic inertia is seen in clinical trials as well as real-world studies. Telemonitoring and teleconsultations becomes easier with this kind of readings. It avoids travel for patients, safety in today's times of like a pandemic, and per se saves time for the healthcare team also. Some instructions which you can give to the patient again. Use devices which are appropriate for the individuals. Appropriate cuff size is what you should look at. Adequate the patient training should be given for measuring their BP or to the relatives at home, and regular verification of measuring technique should be done, especially whenever they come to your clinic and with their blood pressure monitor readings. And values more than 130/85 should be considered elevated if the patients have been having this consistent reading. Duplicate measures is what is advised morning and evening for an initial 7-day period. Single day readings and first home BP values should not be considered. When you talk to the patients about the monitors, assist them, especially with the model and the correct size of the cuff. Understand or make them understand the size of the cuff should be large enough to cover their entire arm or 80 to 100% of the arm. The recommended devices, mainly by the British Hypertension Society or the ISO, is what is recommended. Advise patients that average readings equal to or more than 135 should be considered higher, and a lower threshold is appropriate for those with diabetes or chronic kidney diseases. Of course, the validation is an important aspect for our home blood pressure monitors. It's a clinical test which is done to define the protocol, determine the accuracy of blood pressure monitors. A real world patient study is what is done for these monitors to undergo the validation. Usually with the strength of the study has to be a minimum of 85 patients. Calibration is something different and applies mainly to the mercury and aneroid devices, where the measured BP devices are checked for accuracy. Various guidelines are various societies like the British Hypertension Society, the Advanced in Healthcare Technology, the ISO or the International Standard Society or the European Society of Hypertension are the ones which have laid down validation protocols for different monitors, and the monitors have to undergo the validation test to be considered to be fit in good enough for this. We need to understand that the devices are accurate enough. The number of patients in the validation study has to be looked at. The kind of patients who will be measured with the devices is what to be seen. It should be from all different groups. Did the device pass a validation for a special patient group is what again needs to be highlighted. And does the cuff size range cover the need, and this has been clinically investigated or no? These are the various points that have been seen to be looked at. There is always a question that which are the good devices that you can advise to a patient. There are various devices available. The MicroLife and the Omron are the ones which are the most standard ones. If you look at the various criterias, MicroLife is one of the standard devices which has been validated in various different countries. These are the various oscillometric ones. It has been tried in various conditions where patients are with stiffer arteries like end-stage renal disease, diabetes, elderly, dialysis, preeclampsia, or somebody with a more fluctuating blood pressures like low BP values of hypotension, children and adolescents, obesity, or different cuff ranges. Omron has been tried in some of the conditions, different conditions, and not tried in patients with end-stage renal disease. And there is some machines also which are available, but these are the two standard ones. When you look at the limitations of home blood pressure monitoring, systolic daytime blood pressure was found to be lower in clinical trials with home monitoring children than ABPM, but no difference exists in adults. So home BP monitoring ideally should not be recommended in children less than 12 years of age. In patients with CKD, home blood pressure monitoring does not provide nocturnal beep recordings and therefore does not give ideally the information based on diurnal patterns. And caution should be exercised when you are using this monitoring system in elderly, because there is found to have some underestimation value of 46% in subjects where they have used the cocker of BP in the past. Accuracy of BP measurement has been tried in various monitoring in clinical trials. Again, there was a study in 2009 which used 554 different devices, and there only 30% were found to have acceptable validation. 72% of the automated monitors were found to be inaccurate. Another study with 300 devices found an acceptance of 30 to 40% in various devices. So it is important to look at the validated monitors and advise that only. The match between upper arm circumference and the cuff size is important for the accuracy of HBPM, again highlighting that aspect, and it should cover almost 80 to 100% of the individual circumference. There are some advantages or some innovations which are being tried to overcome the disadvantages of the older machines. So like the home monitoring devices which are now coming up with equipped automated cuff wrapping, which will reduce the error or incorrectly wrapped cuff. A display indicating a correct positioning of devices would definitely reduce the error due to improper posture, and these displays are coming up in newer devices. There are devices which are now getting calibrated or with detect irregular pulses, and which can detect the inaccurate blood pressure. They can also detect noises and wave pulses within the cuff that are caused by arm movements, and they will immediately detect them. One another newer technology that is coming is the IntelliWrap cuff technology. It is basically a longer inflatable cuff within the cuff, inflatable part within the cuff that would cover the entire aspect of the arm, and therefore It would reduce the problem of less pressure on the brachial artery, and therefore there have been clinical studies which have been done with this IntelliRep cuff, where they have compared it to the standard cuff, and where they found out that in spite of the cuff not covering properly, still it could give or reproduce the acceptable blood pressure readings. So the BP values that are obtained by oscillometric devices tend to be lower than by the reference method, but especially if they are done with the standard cuff size. So to summarize, the growing burden of hypertension, as we know, is on increase, and the easy availability of home blood pressure monitoring devices is something which we should be taking advantage of. Home blood pressure monitoring values or the mean values are stable and reproducibility is high. They are cost effective. They have stronger prognostic value in terms of CV risk when compared to the clinic BP measurement. It is easy to incorporate into daily routine, can accurately assess the response to hypertensive therapy and thereby enable telemonitoring. And it is something which would help us assess the patients at risk very easily and should be encouraged to our patients at home. Thank you.
Thank you, Dr. Tejas, for that excellent lecture. It was so clear and lucid. You explained all the practical aspects of home BP monitoring, right from the technique to the instrument, the right instrument or the right brand which has to be used. So I think we will take up the questions at the end. I now hand over the session to my dear friend, Dr. Sukesh, to move on to the next question.
Thank you, Dr. Prashant, and many thanks to Dr. Matthew John and my dear friend, Dr. Titu. So the next talk is something related to type 2 diabetes. We know that we get many patients with type 2 diabetes mellitus with at a very younger age of onset. So our next question will be something like this. Does the age of diabetes onset in type 2 diabetes influence the long-term prognosis? So it's a very important question because we are dealing with many younger patients with type 2 diabetes. So to deal with this, we have Dr. Suresh Damodaran. He has completed his MBBS and MRCP and CCST in internal medicine and CCST in diabetology and endocrinology. He is presently working as a consultant in diabetes and endocrinology at Sri Ramakrishna Hospital, Coimbatore, and he is also the executive council member of the Endocrine Society of India. He has won many prestigious awards, many international awards, and many international publications to his credit. So I am handing over this session to Dr. Suresh Damodaran. Over to you.
Good evening, sir. Can everyone hear me? Hello, can you hear me?
Yes.
Thank you, sir. Thank you, sir. Good evening. Thank you very much for the wonderful introduction, and it's been a real honor to be in this meeting. And thanks, Matthew and Tito, for the excellent job and the technology as well. I think it's really a virtual platform, and it looks very seamless being an hour in the meeting. So as the chairperson mentioned, this is a very challenging topic. I think whatever the research we see, it will be for the people who are in the adult age group, and whatever the evidence we're getting day by day is mainly in the adult age group. We might be getting type 1 studies, but getting the pediatric or the adolescent age group of type 2, there are not much studies, but I'll try to see how we have to approach these people. This is my patient, Asha, age 12, and you can see acanthosis being there, and also the A1C is almost 8. What is the challenge? How do you treat these patients where we just start on medication straight away, and how long they're going to be in medicine? Just imagine 12 and imagine they're going to live until 80 or 90, but imagine the duration of the time that they're going to be on medicine, and what are the long-term complications, and what are the long-term prognosis and side effect and evidence. All of these are all area which is very much gray area. But if you look at the evidence what we got, early onset type 2 diabetes, how do you classify it? How do you just know it's early onset or not? Available data tend to separate early onset into a pediatric and adults of more than 19. That's a cutoff. So why do we need to differentiate? Because the earlier the diagnosis, it is useful for provision, service provision, so we can make sure that the arrangements are there. And also, there are potential poor outcomes in the patient if you are diagnosed a bit later. And the cutoff is usually 45 to demarcate the early onset from usual onset of diabetes. So we know this is no brainer, but a lot of obesity and sedentary lifestyle is the most challenging thing in our kids. And ethnicity, of course, we are the race, we are much more prone to be, and then the GDM, low birth weight. So if you look at it, the early onset type 2s are mostly associated with high BMI. And why? Because if you compare it with non-obese, obese but not diabetic type 2 obese kids, there is the lower insulin sensitivity and glucose disposal when compared with obese non-diabetics. So that is the evidence that we got here. And what happens is, if you've got an early onset of type 2, there is multiple comorbidities early onset, which is like a lipid, and also quite a lot of other things, blood pressure, and also the treatment is also very much challenging. So the clinical impact of early onset, what are the clinical impacts? So early onset is worse in glycemic control. There is no question about it. That is the evidence that we got in 2013. The publication is done. You can see the A1C of 7 is more than 50%, and then 20 to 30% is more than 8 and more than 9. Probably understandably, there are the kids and the early onset guys, the lifestyle will be challenging than who's got a diagnosis more than 40 or 50. So what happens is the impact on microvascular complications, so the higher risk of microvascular complications when compared to type 1 diabetes. If you've got a type 1 diabetes of the age of 12 kid and a type 2 kid, you can see that the high risk of microvascular complications despite the good control. I'll come to the evidence in slightly next few slides, but the lifetime exposure of hyperglycemia. So what happens is the advanced glycated end products and the exposure of the microvascular and macrovascular vasculature itself tend to have, I think Nita was discussing about the multiple cardiovascular risk factors. So if you have that along with the age and the duration of diabetes, then you were going to be in much trouble with the micro and macrovascular complication. So if you look at it reduces the quality of life certainly, and then increased morbidity and then premature mortality. So incidence of neuropathy, that's a microvascular complication. There is one of the studies, almost 57% of the people with positive test in tuning fork in UK, and also almost 60% incident of retrospective, that is in the globally. So if you look at the foot ulceration, because of that, it can manifest almost 2 years after the diagnosis, and the amputation is 10 years after the diagnosis. So it is really frightening what, if you got a type 2 being diagnosed at the early age, what they're going to face up with. However, the retinopathy, is another microvascular complication, which is also very high if you've got an early onset type 2, and the greater risk of retinopathy remains even if the A1C is badly under control. So this is the point I was trying to make. Even if you've got a good control of the blood sugar, the microvascular complication still goes on if you've got an early onset of diabetes. That is frightening. So if you look at the incidence of microalbuminemia, almost 28 to 40% incidence of the 5 year of diagnosis, and 60% is almost 10 years of diagnosis. So if the kid is diagnosed, for example, I'm telling you, it won't be this thing, then the chance of getting, if you got in 2024, by 34 or 40, within 40, they will be getting microvascular complication. And then the end-stage renal disease is a progress of a microalbuminuria. How about the macrovascular disease? I think in the previous talk, the talk before that, I think when Nita was speaking, there was a discussion about it. Cardiovascular risk markers are often present in the early onset type 2. So it can even set on even before the diagnosis. So 26% of adolescents have got hypertension and 50% by almost 4th decade. These are all evidence that is published in Chronic Disease in 2014. So research that found 80% of adolescents have HDL, which is the good cholesterol, and also the triglycerides, which is elevated. So by 4th decade of these continuing, if you like, more multiple risk factors, it means that the older the person gets, the risk is getting much more higher. So higher risk of CAD in early onset, that has been clearly mentioned in this one. If you look at the first graph, that's elderly coronary revascularization, and then the middle coronary revascularization, but the duration of diabetes does matter. So if you got diabetes earlier, the chance of CAD will be early onset. And how about the MI? The evidence is published in Diabetes Care in 2003, and that showed that greater risk of MI in early onset type 2, more so in women. So I just mentioned about the micro and macrovascular journey of a young guy or a young person who've been diagnosed early. How about the mind and psyche? It is going to be a huge challenge because they're going to be in, I don't know, they're going to be in a bar or a school, college, they have to use insulin. I mean, we are facing a bit type 1, but having type 2s, which is going to be primarily diet and lifestyle, it is going to be a huge challenge, which they can't eat a few things, and it is going to be a huge challenge when they have the teenage peers. So the psychological burden on a youth is great, and excellent glucose control they try for, but also they need to take multiple medication, which is the biggest challenge. And more than 65% of the report diabetes severe distress relating to the emotional well-being, if you like. So this is one of the biggest impact. And many fear of wrong information they get into their brain, and higher rates of depression is present. This is also a very important thing. So how do you manage these people? It is going to be a real challenge, as the chairperson was mentioning earlier. How do you manage these people? Because they might need insulin more than what they normally should. If a 45-year-old is being diagnosed after 50 or 60, he might need insulin. But on the other hand, if a 20-year-old is being diagnosed within 30 or 40, there will be a need of insulin, which will be a real psychological blow. And also, you can see the evidence that is published in 2018 showing that higher need of insulin if you got early onset type 2. What are the drugs to be used? You go to the same drug of choice as what you got for type 2. Some has got FDA approval, some hasn't got an FDA approval. I'll just come to the new drug which has been approved in the last few slides. But the target, what we are aiming for, should be extremely tighter. And also we have to individualize, because there may be a person whose lifestyle will be challenging because of night shift and other things, and there may be a really young one with other renal or other impact of complications or another autoimmune disease that may be present along with it. So maybe individualization of individual condition is very, very essential. A1C of 6.5 can remain high in target of majority of patients. The new concept of timing range can be set that I think we should be happy if it is only 70 to 80% of the people are attaining the target. So the basal insulin is the easier choice if you need an insulin, and the basal insulin will be the choice rather than BD insulin, even if you think it's an appropriate way to go for a BD insulin or a basal bolus. But I think the better idea is to start on a basal insulin to minimize the psychological impact and to minimize what it is, insulin phobia, if you like. So almost end of my talk. So this is the generation what we are going to get with the early onset. And as I mentioned in my first slide, the early onset of diabetes is mainly relating to obesity or weight gain. So in that case, we are going to see the generations where it is going to be extremely challenging with not only for the micro and macrovascular complications that I mentioned, and also I've also briefly mentioned about the heart disease and other things, and the renal aspect of it with the evidence. But these are the other things that is going to be impacting, which is the hormonal changes that is going to impact the new generation. So if you look at the gut to brain axis, multi-hormonal for the body weight, if you've got an adipose tissue, you can see the leptin, insulin, amylin, PYY and GLP, everything changes in a big way. So it's a gut to brain signal, and the fat is also plays a main role. So these kids who's going to be fat and diabetic is going to be facing a huge challenge for us, not only for the economic burden, but it's mainly the management challenge that what we're going to face up with. But we should be opening our eyes and looking for the other things like hormonal changes, and also the other things like obstructive sleep apnea, which is also coming up in early onset diabetics. So there is evidence coming out with the kids with OSA. There are respiratory consultants in the pediatric aspect. They are very interested in kids having OSA. So it is going to be a big challenge and a big science like what we are having at COVIDology. This area of kids getting obese and becoming diabetes is going to be a huge challenge, and that is what is happening in a developed country like US. So in summary, if you got an aggressive therapy, make use of it. We should do it for the kids, and whatever the resource available, we do need to use it. And insulin, if you want to use the basal insulin, will be the way forward initially. Other agents we can use to prevent the neuropathy, if you see the right hand column, and the retinopathy, and then the cardiovascular disease. So you can see that diagnosed below and above 40, there is a clear difference. So ladies and gentlemen, you should take the early onset type 2 with real seriousness, not only preventing the long-term complications of micro and macrovascular complication, but also the psychological impact for the kid. And also with the COVID emerging, we should be much more alert with the infections. And also the one more thing is the hormonal changes and the metabolic changes, like hormonal changes like hypogonadotrophic hypogonadism because of leptin, and also the OSA because of obesity. So this is the drug I was mentioning. Victoza has been licensed by FDA very recently. That is because of ELLIPS trial that showed there is a huge benefit, and it has been approved for the kids of 10 to 17. But it's all very expensive drugs. I'm not advocating that should go in first. Always just go for a lifestyle modification with strict incorporation of diet and exercise. And metformin is a gold standard that will do wonders in treatment. And I use in my practice, I'm sure you are, and other drugs can be used with caution. But insulin should be started if needed, and basal insulin is a way forward. But the aggressive therapy is needed for preventing long-term complication. I'll stop there, and I'll take the questions at the end of the other talks. Thank you.
Thank you, Dr. Suresh, for that excellent clarification of the topic. And also, like the final summary is that excellent control of diabetes is required, whatever be the age of onset of diabetes. So I'm handing over this to my co-chair for the next talk.
Thank you, Dr. Suresh. We'll move on to the next lecture. Again, it's a very important practical problem we are discussing. We are going to discuss the problem of postprandial hyperglycemia. And for this, we have another excellent speaker, Dr. Jeevan Joseph. I will introduce him. He is currently working as a director of Jeevan's Diabetes and Endocrine Center at Vimala Hospital, Kottayam. He has also worked as senior consultant at Caritas Hospital, Kottayam, and the NMC Specialty Hospital in UAE. Dr. Jeevan has served as consultant in diabetes and endocrinology at South Tyneside District Hospital, South Shields in the UK. And he also has got several publications in national and international journals. So he'll be talking about a very important problem, this problem of postprandial hyperglycemia, and how to tackle this, and should we really target the postprandial sugar. Over to you, Dr. Jeevan.
Thank you very much, Dr. Prashant, for your kind introduction, and thank you to the Providence team for asking me to speak. I think in terms of looking and understanding diabetic dysglycemia, postprandial hyperglycemia has kind of resurrected itself as and reappeared as a new kid on the block. And I'm very pleased to be looking at the evidence base for postprandial hyperglycemia and whether we should treat that to target. So the first thing to actually understand is that postprandial spikes are in glucose are actually part of the normal physiological process, but they rarely go above 140 milligrams per deciliter in a non-diabetic situation. And what we're really concerned about in this is why they spike above that. What might be the importance of understanding the relevance of this? And to make it very focused, I have a series of questions that I'm going to be answering. So the first question is, why do people with diabetes have postprandial spikes in glucose? And the answer, part of the answer, which we all know, is especially in the Indian context, is the very high carbohydrate content in our meals, 60 to 70%, as compared to probably about 40% in a Caucasian diet. But clearly, this is not the entire story. If you look at the pathophysiology, really, it's the loss of the early phase of the spike of the insulin, in the early release of insulin in response to a glucose challenge. We need to recognize that diabetes is a bihormonal disease, and there's also the excess production and the non-suppression of plasma glucagon. What this does is that there is increased production of glucose from the liver. This is something that we need to understand, because it's not just about the food that we eat. And all of this leads to a spike in the plasma glucose. So there are multiple pathophysiologies involved, primarily three. One is obviously your meal size and what you're eating. Secondly, it's the endogenous glucose production, primarily from the liver. And the third one is obviously what is being done with that glucose in terms of the disposal in the peripheral tissues. So one of the key concepts is that hepatic glucose production also accounts for a significant part of postprandial hyperglycemia in type 2 diabetes. You can look at the slide on the right, which says that it's about 28% is the contribution of that in terms of the postprandial glycemic spikes in type 2 diabetes. Why is this important? Because it's important to recognize that postprandial glycemia, hyperglycemia results from the loss of the early insulin release in type 2 diabetes. Also, that early initiation of insulin actually suppresses the hepatic glucose production, and that can limit postprandial glucose excursions in type 2 diabetes. And also, this allows us to understand the relevance of other hormones that might be used in actually suppressing the glucagon production, which might help to deal with postprandial glycemia. Second question, do these spikes actually matter? So we know that we've always focused on fasting glucose and HbA1cs, but almost 40% of patients who have a good HbA1c, in inverted commas, might have significant glucose variability, might have postprandial spikes. We understand that if you want to really get a good HbA1c, you need to focus on both fasting plasma glucose and postprandial glucose. I will not go through this slide in any detail. I'm sure all of you are aware of it. So having understood that these spikes do matter in terms of our gold standard HbA1c, do these spikes have any independent deleterious effects independent of a suboptimal HbA1c? So this is the key question, really. Is there any difference other than understanding how they impact HbA1c? And the best study for this, or one of the very good studies in this, is the DECODE study published in the Lancet, which essentially showed, in summary, that you can see here, that irrespective of whatever your fasting plasma glucose is, if your 2-hour postprandial glucose is on the higher side, then that increases your relative risk of death. So you can see here on the extreme left, even if your fasting plasma glucose is less than 110, as your postprandials begin to rise, you actually have a higher risk of dying. If you look at what happens to people after a myocardial infarction, one of the significant factors that has a good predictive value of a subsequent myocardial event or a subsequent MACE is actually the glycemic excursions of that particular patient to greater than 70 milligrams per deciliter, high and low. It's not actually your HbA1c. So glycemic excursions do matter. And if you look at this study, which looked at elderly people who had already had an MI, and pursued one arm with a prandial insulin strategy and one arm with a basal insulin strategy, they found that it was better in terms of in preventing a subsequent myocardial event if you followed a prandial insulin strategy, focusing on postprandial glucose. So PPGs are important. And this is actually a very good epidemiological study, which is looking at a 33-year survival rate based on a 2-hour 50-gram GTT, essentially showing that as there is a continuum of risk that rises above 83 milligrams of deciliter 2 hours post glucose load, you can actually predict what is going to happen to these people 10 years, 20 years, 30 years down the line based on what they do after a 50-gram glucose challenge. Clearly, that is important irrespective of your HbA1c, or gives us something more than just an HbA1c. The next question is, what value do you then target? Do you want to look at a 2-hour value, or do you want to look at a 1-hour value? There's evidence from Cavalot et al., who published essentially telling us that 2-hour postprandial glucose is a very strong predictor of cardiovascular events compared to fasting plasma glucose. So we had some evidence that 2-hour PPG has some independent predictive value. And we have some recent evidence saying that actually the 1-hour postprandial glucose might be even more significant in predicting oxidative stress, in predicting endothelial dysfunction and other things. So there's a question that we really need to answer, which is there a need for a paradigm shift in terms of what PPGs we are focusing on? We've always focused on 1-hour PPGs when we look at gestational diabetes, but outwith of that, we've always looked at the 2-hour role. Trying to clarify this even further, the Israelis did a 33-year follow-up looking at the clinical implications of 1-hour postprandial glucose control. And I don't have time to go through all of it, but essentially, in a nutshell, if you look at the second slide, which is the second part of it, second line, which is B, even if your 2-hour postprandial glucose was less than 140, your mortality was higher if your 1-hour postprandial glucose was above 155. So a 1-hour PPG of greater than 155 predicts a 28% increased risk, even when the 2-hour postprandial glucose is below the gold standard of 140. So 2-hour PPG may not be the entire story, and it's watch this space as we look at it. Okay, so now that we know that we need to look at this, how do we actually capture it? How do we actually really look at it? And the whole concept of time in range, again, for brevity, I will not go into it, but continuous glucose monitoring has given us an entirely different picture of how to look at dysglycemia, and obviously looking at postprandial spikes is part of it. There's also the glycomark test, which is FDA approved, used widely in the US, and you might see it here in India as well, which looks at 1,5-anhydroglucitol, which is a very good marker of a postprandial spikes over a 2-week period, and with a marker of less than 10, suggesting high postprandial sugars, even in those with HbA1c of less than of 7% or less. You can just see here, you can see the second person is a 49-year-old male with an HbA1c of 7.2%. You might pass that as a very good control, but if you look at his 1,5-anhydroglucitol, it's less than 10, it's 4.5, which actually says that over the last 2 weeks, this chap has been having significant postprandial excursion. So it's a very good marker and adjunct that you can use along with the HbA1c, something that you might see here in the near future. Therapeutics. How do you want to, now that you've understood that it's important, how it relates to mortality, we think we know how we can measure it, how do we actually do something about it? Obviously, especially for type 1 diabetes, carbohydrate counting, carbohydrate control, understanding your portion size, understanding the diet, glycemic index, correlation with lipids, a high fat meal, etc. All this is very important. If you look at oral agents, you have the meglitinides like repaglinide, natiglinide, which are traditionally being used to deal with postprandial spikes. You have alpha glucosidase inhibitors, both acarbose and voglibose. And if we understand the physiology of the high hepatic glucose production, then you can understand why DPP-4 inhibitors and injectable GLP-1 agents, especially the shorter acting injectable GLP-1s like lixisenatide, etc., might have a big role to play in terms of managing postprandial spikes. If you look at what is new in terms of insulin, we've always been trying to shift the curve to the left in terms of trying to mimic normal physiology. So from regular insulin to rapid acting insulin, trying to mimic what the normal pancreas does. And we now have ultra fast acting insulins, again, trying to deal with this. If you look at the previous kits that were on the block, there's data from pharmacokinetic and pharmacodynamic studies that probably glulysin, which is the only zinc-free insulin of the previous lot, had faster onset of action. Whether that actually translates into clinically meaningful outcomes, we don't have data for that. There's also a trial which has looked at glulysin versus aspart in obese type 2 diabetes, showing that glulysin has a better control of postprandial spikes at 1 hour. Although over the entire period of that study, if you looked at the 6-hour window, there was no particular difference. So if you think that 1 hour postprandial glucose is important, then you might want to take a closer look at this study. Obviously, aspart has been catching up with the faster acting aspart, which is an ultra fast acting insulin with niacinamide in it, which actually makes it easier for it to form monomers and quicker absorption into the bloodstream, essentially trying to target the postprandial spike, essentially within the first 1 hour. If you look at the graph for this, you can see here that if regular aspart is at 21 minutes, then fast acting aspart is at about 16 minutes. So it's twice as fast in terms of appearance in the bloodstream, and probably a 74% greater glucose lowering effect within the first 30 minutes. Again, this makes sense if you think that the 1 year post, the 1 hour postprandial glucose is something to be targeted. So that's why I presented the evidence for that as well. And if you look at what evidence faster acting aspart has, in type 1 diabetes, it certainly gives superior 1 hour and 2 hour postprandial controls versus insulin aspart. And in type 2 diabetes, the 2 hour values were non-significant, but at 1 hour, it has better postprandial control. So all of this is in terms of what we can do to target postprandial spikes. So let me summarize by saying that the relative contribution of postprandial glycemia to overall HbA1c is significant. We all recognize this. PPG is probably an independent predictor of cardiovascular risk, as we know from the DECODE study and the various other post-myocardial studies that I presented, and also the epidemiological study of the 33-year follow-up, etc. There's some evidence that actually 2-hour PPG may not be the whole story, and high glycemic spikes at 1 hour may be even more significant in terms of the oxidative stress, in terms of endothelial dysfunction, damage, etc. There's also some data about carotid intimal thickening and carotid and coronary artery thickening, etc., which for paucity of time I did not present. And newer therapeutic molecules like faster acting insulins, in addition to the basics of carbohydrate counting and our oral hypoglycemic agents, which we've always used, can help in treating PPG to target. Thank you very much.
Thank you, Dr. Jeevan, for that enlightening lecture. I think we will quickly move on to the next session, and we will take the questions at the end. There has been a slight change in the schedule. The next speaker is none other than Dr. Jabbar. Jabbar sir needs no introduction to this audience. He is the Professor and Head of Endocrinology Department of Medical College Trivandrum and the senior most endocrinologist in the state. And he'll be dealing with a very interesting topic, a less commonly discussed topic: should bone health be a priority in patients with diabetes? So we all know that there is some amount of decrease in the bone mineral density which happens in patients with diabetes. There are multiple factors which are affecting that. It could be related to the adipose tissue mass. It could be related to the overall nutrition of the patient. And as we had a very good discussion previously regarding the use of SGLT2 inhibitors and sarcopenia, the therapies used for diabetes could also affect the bone mass in patients with type 2 diabetes. So over to you, Jabbar sir, for your lecture. You can unmute yourself, sir.
Good evening. Good evening. Am I audible?
Yes, sir. Yes, sir. Yes,
Am
sir.
I audible?
Okay.
You're audible, sir.
Yes, sir.
Yeah. Good evening. Good evening, Chair. First, I should thank my friend Dr. Matthew and Titu for the wonderful opportunity given to me. And this topic is a very unique topic. Okay, it's something very important in our clinical practice, which most of the time we are not looking into. The topic is osteoporosis, and the bone health is really important for us before choosing a molecule for the treatment of type 2. There's a definite link between osteoporosis and type 1. The bone mass occurs or peak bone mass occurs around 30 years. So suppose if you have a patient develops diabetes mellitus at a younger age, they will not develop peak bone mass. So eventually what will happen? You will develop weak bone, or you can call it as osteoporosis. And in addition to that, especially for type 1 diabetes and all, you have lot of cytokines, which is also contributing for your bone health. So if you see this diagram, see what is written here in the initially up to 20 years or little later than, you'll get maximum bone mineral density, and subsequently that is coming down. That is what is happening in normal individual. Suppose a patient gets diabetes also, what will happen? The peak bone mass is not achieving properly, and the reduction is also significant. So in effect, these patients are high risk candidates for developing bone changes, and subsequently fracture is possible. Now there's a beautiful diagram which is given in 14th edition of Williams. What it shows, the insulin is favoring the function of osteoblast as well as the osteoclast. So if you can read the lower part, under carboxylated osteocalcin, which has got some positive impact, it will increase the insulin sensitivity and insulin secretion. So what I want to tell you that there is something like a crosstalk which is happening all the time between adipose tissue, insulin, and bone. Now the link, if you look into the data again and again, what I want to tell you from these slide, even in type 2 diabetes mellitus, there is a risk for fracture, and in type 1 diabetes mellitus, there is no doubt about that fracture risk is high. So these are the studies conducted, quoted in the various literature. IVO human health study, lot of people were included or enrolled for the study. Even for type 1 diabetes also, lot of patients were involved, around 8 lakh patients. So what is the take-home message? Take-home message is very, very simple. So diabetes mellitus and bone has got definite relation. Eventually, diabetes can affect the bone strength, subsequent fall. Now, this data from Osteoporosis International Journals around 13 years back, this indicates on the left side, you can see the fracture risk of for type 1 diabetes mellitus is very, very significant. But fortunately, common type of diabetes mellitus fracture is not very common. Now, if you look into the sites for fracture, what are the sites? Is it spine alone or is it hip alone? What it shows, you can see this, any fracture, the p-value is very, very significant. And see, only the lower arm fracture, it was not very significant. So the take-home message from this slide, see, all areas in our body, see, starting from pelvis, upper arm, spine, everywhere, the risk of fracture is increased in type 1 diabetes mellitus. This is a bird's eye view of frequency or the prevalence of osteoporosis or fracture. The 2 dozens of studies you can see from the left side. So what is the link between the fracture and bone fragility? On the left side, you can see there is hyperglycemia and low bone turnover. That is one hand. Another, the mid panel, there is hyperinsulinemia. See, production of advanced glycation end products, and the treatment is also contributing for that. And there is a high incidence of hypovitaminosis, especially this part of world is very, very common. So what will happen? The eventual result would be low bone quality. And on the right side, there are other risk factors which is producing little bit extra incidence of fall, and eventually because of these 3 factors, the risk for developing fracture is very, very high. Now, this is very simple diagrammatic representation. This is control. Once the patient develops fracture, you can see here another lot of porosity. So eventually, this patient will go for lot of fractures. Now, coming to a very controversial issue, what is the diagnosis? Is it the classical 2.5 or is it more than that? Please read. There are little modification in the the T-score is 0.59 and 0.38 for males. This is what is happening. So it's not the usual type of definition. You should modify the definition. This is clearly written, clearly showed in the studies and quoted in 14th edition of Williams. Now, let us examine what is happening with poor control. So if you see the glycosylated hemoglobin of 10, the fracture risk is very high. So with a very good glycosylated hemoglobin, fracture risk is high. Now people are looking in a different way. What about the difference between standard and intensive glycemic control? What it shows, significant difference in the BMD between standard or in the intensive treatment. They looked into the total hip, femur neck, lumbar spine, and whole body. There is no significant difference was noted in terms of B. Now, coming to the fracture or fall, it also shows the increase in the risk of hypoglycemia in intensive treatment, but there was no increased risk of falls. But one thing is very sure, good control is essential. Now, coming to the most important for a practicing physician, practicing diabetes mellitus, what is the impact of treatment agents? There are negative impact with a certain molecule, especially glitazone controversy. There is something known as a good molecule. There is something known as neutral molecule. We'll examine. So this is the effect of metformin. Metformin is a good molecule in many ways. Basically, that will increase the level of AMP bar ATP level. Eventually, the Wrangle system is getting modified, and Run-X2 system is also modified. The patient's osteoblastic system is very good. So what will be the result? Your bone density may be good, and on the lower panel, you can see the osteoclastic activity is being suppressed with metformin. So eventually, metformin becomes one of the fanciest molecule for the bone health. Now, coming to the controversial molecule, what is this glitazone? Glitazones, everybody knows that the glitazone is good molecule for selected group of patients. But most important issue is little bone problems. And of course, controversy I'm not discussing here. So what exactly is happening here? You can see here the mesenchymal stem cell. In presence of glitazone, what will happen? A lot of fatty or adipose tissues are coming up. So in the osteoblast, quality and quantitatively that will come down. And marrow adipose tissue structure is also altered with your glitazones. So finally, this patient, especially for ladies, thin patients, you can get more fracture, more fragility fracture with the glitazones. This is a study from ADOPT study. What it shows, you can see the incidence of the blue line you can see here. The rosiglitazone, the fracture, the cumulative incidence of fracture was high compared to gliburide. Gliburide was okay in the ADOPT study, Khan's paper. Gliburide was okay, metformin was okay, but rosiglitazone is a negative molecule in terms of bone health. Now, there are a lot of meta-analysis, randomized control studies you have, where it clearly showed low-risk women, 1 fracture per 55, and high-risk patients, definitely patients high-risk candidates for vascular bone fracture. So what would be the carrier message? Carrier message is very simple. Glitazone has got a negative impact on bone health. Coming to the good molecules, that is GLP receptor agonist. GLP is expressed in osteoblasts, is good. That will help for the remodeling. GLP-2 receptors were the osteoclast class. So eventually or finally, there will be a reduction of bone reabsorption. So what I want to tell you that incretin-based treatment, you have evidence-based medicine also for liraglutide. There are certain data which showed the increase in the BMD, of course, the animal data only. And exanitinide, unfortunately, did not show any significant improvement in the BMD. Of course, controversies are there. These are the mechanisms. See, good effect on the osteoblast. On the right side, you can see a negative effect on the osteoclast. So what will be the effect? If you are using GLP or incretin-based treatment, at least the bone-friendly attitude of the molecule you can see. So this will be one of the good molecule if the patient has got osteoporosis. And coming to the second part of the DPP-4 drugs, definitely these molecules are good. molecules are good because that can increase the calcium accretion, and these receptors in the osteoblast, that will reduce the apoptosis also, and that will inhibit the PTH or parathyroid PTH induced bond resorption, and thyroid C cells also express in the GLP-1 receptors, and their activation stimulate the secretion of calcitonin. So this will be a potent inhibitor of osteoclastic resorption. My friends, what I want to tell you that these molecules got a good impact on bone health. Sitagliptin showed significant improvement in the vertebral BMD. Vildagliptin also showing some green signal, and the one trial which showed the effect of glycoside, sulfonylurea, which showed all these molecules are good, especially these DPP4 molecules. Now, so SGL2, little controversial point. Canvas trial was a negative trial in terms of bone health, but it is not really replicated in the subsequent study. Empagliflozin, no significant risk was documented in the EMBARAG study, and dapagliflozin also probably there is no risk at all. And one Cohen et al., they investigated the efficacy or the friendly attitude of dapagliflozin in mild renal failure also. And everything put together, these molecules are good in terms of bone health. Now, there are a lot of mechanisms which are described for the increased fracture risk with SGL2, postural hypertension, loss of fat. So less aromatization, less estrogen, eventually bone will become little more weak, and SGL2 leads to poor bone mechanical quality. So there are a lot of mechanisms are operating. Eventually this can go for, theoretically this can go for fracture risk. Simple diagram. Metformin is a good molecule, and GLP-1 and DPP4 molecules are good because of multiple mechanisms, except glitazones, which has got a negative effect on bone health. Now, coming to the biomarkers, you can concentrate only the central one. The glitazones bond resorption is very, very high. It is not a good molecule for us. Here it's okay. See the metformin sulfonylurea and incretin is very good. So glitazone is not good. Sulfonylurea is okay. Metformin is okay. GLP and the incretin-based treatment is very good. And SGL2, little controversy is there. And insulin is a neutral one. Now, considering all these issues, the people are coming with a lot of recommendation. This is published in JCM 2017 and Ferrari article also. What it shows, you go for the BMD. Accordingly, you can categorize a patient. Of course, all patients you should give calcium and vitamin D, anti-fracture treatment, good anti-resorptive agents are there, and the maximum experience with the anti-resorptive agent. But coming to the anti-diabetes management, you have three group of molecule: neutral or positive effect, that is metformin, DPP4 drugs, and GLP receptor agonist. Risk of hypoglycemia, because of risk of hypoglycemia, insulin probably little problem, and sulfonylurea it's okay, say neutral effect. But please, my friends, use with caution. Two group of molecule, one is glitazones and other one is SGL2. Now, I conclude my friends, ladies and gentlemen, and remember, type 2 diabetes mellitus is a risk factor for vascular disease, and a comprehensive management include your vitamin D, calcium, and anti-resorptive management. That's a standard recommendation. And if you are choosing a molecule for the treatment of diabetes mellitus, look into the bone aspect and choose a good molecule which is friendly with your bone. That is very important. Let me stop here. Thank you very much for the kind attention. And once again, thanks to the organizing team for the wonderful platform. Thank you. Over to organizers.
Thank you, Jabbar sir, once again for that enlightening lecture. You have clearly showed the importance of individualizing treatment when it comes to the aspect of bone health, which is less taken care of in choosing a therapy. We will come to the questions at the end. I think I will hand over the session to Dr. Sugesh once again for introducing the last speaker of the session.
Thank you, Dr. Prashant. Last talk is done by Dr. Tushan Thomas. The last talk is something, it's a very interesting topic. Why? Because many doctors and many of our patients have a doubt. What is the ideal time to do a lipid profile? Because one of the major concerns is that to do a lipid profile along with the fasting sugar, the patient has to reach very early to the hospital. And it will create a lot of trouble for the patient because he has to wait for the other reports to come to see the doctor, wait in the OP cabin, wait near the OP cabin, and then he has to see his postprandial blood sugar, and then only he can go. If the lipid profile can be done at any point of the day or any time of the day, what he does is that he'll save a lot of time because he can do a glucometer monitoring of his fasting sugar and can come to visit his doctor. So about the speaker, Dr. Tushan Thomas, who is a medical school colleague of mine. He is a consultant endocrinologist in the KIMS Hospital, Trivandrum. And he has done presentations at ISBMR and ASICON. And he was a member of the co-organizing team of ASICON 2017 as the treasurer. And he has various publications in peer-reviewed journals. Over to Dr. Tushan.
Good evening, dear friends. I'm audible, right?
Dr. Tushan, can you share your slide?
Yeah, I am audible, right?
Yes, yes.
You are audible,
very much.
You can start sharing.
Please share.
It's showing you cannot start screen share while the other participant is sharing.
You can share now.
Is it visible, right? My slide?
Yeah, it's visible. It's visible.
Yeah. Good evening, dear friends. Thanks, Dr. Sugesh, for the kind introduction. And at the outset, let me thank Dr. Matthew and Dr. Titu for having given me this opportunity. So coming to the topic proper, lipid profile, whether to do it in the fasting state or not. Sugesh has already given a very nice introduction to the relevance of the topic. So conventionally, in clinical practice, lipid profile has been done in fasting. For fasting means at least 8 hours of fasting it has been done. And but we exist mostly in the non-fasting state because if you look at the exact fasting hours in our 24 hours, it may be around 6 or 8 hours or something like that. So most of the time we are in a non-fasting state. So non-fasting state is our habitual physiological status. So if you do a fasting state, it may not reflect the daily average plasma lipid and lipoprotein concentrations and associated risk of cardiovascular disease. And interestingly, evidence is lacking that fasting is superior to non-fasting when evaluating the lipid profile for cardiovascular risk assessment. So this is what I meant in the previous slide, or when I told regarding the fasting and non-fasting state. So majority of our time we are in the non-fasting state, and the true fasting hours is maybe around 6 to 7 hours in the early morning hours. And lipid profile usually contains these molecules. We look at the triglycerides, HDL, LDL, and the total cholesterol. This is what we usually look at. And basically, the concept of non-HDL cholesterol is also coming up, and it is more recognized as a cardiovascular risk marker now, which means that it's a total cholesterol minus the HDL cholesterol. So actually, if you look at the non-HDL cholesterol, both of these, like the measurements required for that, the total cholesterol and the HDL cholesterol, they are hardly affected by the fasting or non-fasting state. So to assess the cardiovascular risk based on a non-HDL cholesterol, it would be very, it can be very easily be done in a non-fasting state. So some of the perceived limitations of a non-fasting sample. That means if you are going for a non-fasting sample, what are the perceived limitations of that? One is the convention has been to go for a fasting sample. Over the last so many years, we have gone for the fasting sample. Then fasting lipid profile is believed to provide more standardized measurements. Then it is believed that non-fasting lipid profiles can lead on to less accurate measurement because we are using the Friedewald equation for calculating the LDL, and changes in the molecule, the individual components, especially the triglycerides, can lead on to erroneous measurement of the LDL cholesterol. And fasting has been the clinical standard, and most of the labs use the values based on fasting value for the flagging of the abnormal reports. So we don't have a non-fasting standards as of now regarding which value to be flagged and which value to be not flagged as abnormal. So those were the points supporting the fasting values. Like it has been the convention, and it is supposed to be more standardized. And regarding the postprandial concentrations of the lipid components, which can make the Friedwald equation erroneous. These are some of the points which would support the fasting sample. So, but there are some points which can act against this. The arguments against the points of fasting sample. So one of the reasons supporting the fasting sample is the increased triglyceride levels, which can be seen during a fat tolerance test. So fat tolerance test is just like the glucose tolerance test, in which they are given a fat load, like 1 gram per kilogram body weight of fat is given to the patient, and then after that the lipid profile components are measured after that. So that much high fasting, the fat content we are not usually taking in our day-to-day meals. Our individual meals like breakfast, lunch, or dinner, or if you take breakfast alone, it will not contain that much fat. If you look at the Western population, it may still have a higher fat content, whereas in our part of the world, where the breakfast is especially not that much fat containing, the effect of the dietary fat on the post meal, like the profile value, especially the triglyceride values, may not be that much. And in areas where fast food consumption is very high, the patients can be advised to avoid a high-fat fast food meals on the day of lipid profile testing, like somebody taking a heavy cheese hamburger with a milkshake along with that with French fries. In such a scenario, the diet would be containing very, very high fat content. Otherwise, especially our diet, especially the breakfast, doesn't contain much of fat. So a very high fat content diet should be avoided on the day of lipid profile testing. Otherwise, our diet doesn't contain that much fat, especially in our breakfast. And then regarding the Friedwald equation, because in Friedwald equation, that is what has been used conventionally in lipid profile. Usually the total cholesterol, triglycerides, and the HDL is measured, and then LDL is calculated from this. LDL is calculated from this in the sense that VLDL we get by dividing triglyceride by 5, and then VLDL and the HDL, the sum is subtracted from the total cholesterol. That's the way in which LDL we obtain. So that means that when there is change in the triglyceride levels, you can have erroneous LDL cholesterol values. So that is one of the points which is favoring a fasting value. But here you can see that when you look at the Friedwald equation derived LDL cholesterol and the directly measured LDL cholesterol, you can see that both of them are almost similar. There is not much of difference which is arising between these two. So even if you go for a Friedwald based LDL cholesterol calculation in the postprandial state, it actually correlates very well with the direct LDL concentration. And nowadays, many labs are actually doing direct LDL concentration also. So that problem also can be taken away. And even one of the articles I saw a modification of the Friedwald equation based on this change which can occur in the triglyceride levels in the postprandial state. That also has been proposed. And some other points favoring the fasting sample is that many RCTs for lipid lowering therapies have used fasting lipid levels, and there is evidence base for fasting lipid levels, and so it should be the standard. Whereas you can see on the right side of the slide that a large number of studies are there in which non-fasting samples have been studied, population-based studies, and even 3 randomized controlled trials using statins have been done in which non-fasting samples have been used. So we have enough data to support a non-fasting sample now. Now coming to the effect of food on lipid profile, how it alters. Actually, the effect is very less, negligible. We will see. So we can see that the total cholesterol, HDL, and LDL are not that much changed in the postprandial stage, whereas the main change would be in triglycerides, which is seen for around 4 to 6 hours after the meal. And the mean difference is like this: triglycerides on an average 26 milligram, it can go up. Total cholesterol and LDL usually reduction by 8 milligram. And non-HDL cholesterol also reduction by around 8 milligram, whereas HDL cholesterol is not changed in the postprandial stage. So if you're going for a non-HDL cholesterol calculation, it will not have much changes because the total cholesterol hardly any change, and that would be the only change which is expected in the non-HDL cholesterol. So in the postprandial stage, among the components, triglyceride is the only one showing some sort of a difference. That is around, you can see in this several studies also, around triglycerides somewhere between 10 to 20% of difference has been there, whereas in cholesterol, total cholesterol, I can see somewhere around 5%. HDL, not much of change. LDL also around 4 to 5%. The only study you can see, the fourth one, the Langsted and Nordistat study, in which they showed that in one of the studies, LDL changed by around 23 milligrams in the postprandial stage, and that is one of the drawbacks which they have discussed. And but this has been seen even in the this has been correlated with the changes in albumin, and the main mechanism that they describe for this is that there is hemodilution in the postprandial stage because of the fluid intake, and that can lead on to reduction in the albumin levels also, in addition to the reduction in the cholesterol levels. So this is proposed to be because of the fluid intake, and this can even be there during the fasting state also, because in the fasting state the patient is allowed to take fluids, and that can lead on to changes in the LDL cholesterol even in the fasting state also. So to overcome this, they have told that actually the fluid intake should be restricted. Otherwise, the same effect would be there in the fasting state as well as in the postprandial state as far as the LDL cholesterol levels are concerned. So this is one of the drawbacks which they have mentioned, but that will be there in the fasting state also if the patient takes fluids. So only limitation of fluid can be the way in which we can overcome this. So these are some of the changes in postprandial values of the lipid profile. Especially triglycerides can go up to by around 26 milligrams. Others usually changes is around 8 milligram per deciliter. This is one another study from Denmark, in which they looked at LDL cholesterol levels and triglyceride levels in the postprandial stage and compared it with the fasting state, and you can see that it's almost similar. And actually, you can see the distribution is actually more better in the postprandial stage as compared to the fasting stage. The variations are actually higher in the fasting stage as compared to the postprandial stage. So this is what I discussed previously regarding the some reduction in LDL cholesterol levels seen in the postprandial stage, and usually it is around 8 milligram, but in one of the studies up to 24 milligram was described. But that can be the problem with that is that sometimes it can lead on to erroneous calculation as far as the cardiovascular risk of the patient is concerned. We will maybe if the LDL cholesterol falls by that much, like 24, we will if the LDL cholesterol came as say 90 or 100 instead of say 120 or 130, we will tell the patient that your LDL cholesterol is not that much high. But nowadays we go more based on the overall risk of the patient. We don't go by just the values alone. We assess the risk of the patient on an average. Then we start statins for the patient. So starting statins based on LDL cholesterol is not that much of a practice now. We use it more for ensuring the compliance of the patient, and use it for treatment targets in patients with established disease. So this fall may not be that much important in the current scenario, but this point has been brought out in one of the articles. That's why I put up here. And association of food intake with the cardiovascular risk. Again, since 1970, several reports have been published that non-fasting lipids are also is also a good marker of cardiovascular disease risk. And the meta-analysis with 68 prospective studies, over 3 lakh individuals were studied, and it has been found that there is not much of difference between the fasting and post non-fasting the lipid values and the association with cardiovascular risk. And indeed, the non-fasting non-HDL cholesterol and non-fasting calculated LDL cholesterol were superior to fasting measurements for predicting the cardiovascular risk. This is the comparison between the highest and the lowest quintiles of random non-fasting lipids, lipoproteins, and various apolipoproteins, and the associated risk of IHD and MI. And you can see that the association between the highest and the lowest quintiles, you can see the risk, and it has been seen uniformly across all the various parameters that in non-fasting samples are also you are getting that well described as a risk with the high incidence of coronary artery disease. So we looked first we saw the effect of food on the lipid levels, and then we have seen that even the effect of food on the cardiovascular risk is also correlating well with the non-fasting samples as compared to that of even the fasting samples. So we have enough evidence to suggest that non-fasting samples can be a good way. So non-fasting samples, they have prospective evidence of more than 3 lakh patients, new guidelines, practical. It is more practical, safe, cost saving, same visit and time efficient. So in several ways, non-fasting samples have an advantage over the fasting sample. So non-fasting samples are a better option for the patient because it simplifies the procedure and enabling blood to be drawn at any time of the day, eliminating the need to ask patients to return for a next visit, because if the patient came without fasting today, you will have to ask them to come back tomorrow or day after tomorrow with the fasting report. So patient did not come back again. And patient, if he has to come back, it actually adds on to the workload of the clinic also, that we have to see the reports on another day. So that also can be brought out. And it is helpful for the laboratory also, because otherwise a large number of patients would queue up in the laboratory in the morning hours. Because otherwise they can come at different times of the day. That can help in reducing the laboratory rush also. And especially it can be helpful in diabetic patients because they need not be fasting for a long period of time. So taking all these factors together, shifting from a fasting to non-fasting samples for lipid profiles would be health, time, and cost saving. And because of this, we can see that a large number of organizations have now propagate even going for the non-fasting sample. So particularly from 2016 onwards, the use of non-fasting lipid profiles have been endorsed widely. These are the various agents which are endorsing it. So this is from the 2016 European Atherosclerosis Society and the European Federation for Lab Medicine. They recommend that fasting is not routinely required for assessing the plasma lipid profile. But when you see that the triglyceride levels are more than 440 in the non-fasting state, we should give consideration to repeat it in the fasting state. And the laboratory cutoff should be changed accordingly if we are going for a non-fasting sample. But having said that, it's not that all the patients can go for a fasting sample. Can go for a non-fasting sample. So we need to go for a fasting sample if the non-fasting triglycerides came as say more than 440. In patients with a non-hypertriglyceridemia followed up in a lipid clinic, patients who are recovering from hypertriglyceridemic pancreatitis, and patients who are planned for drugs that can cause severe hypertriglyceridemia like ART, estrogens, high-dose steroids, retinoic acid, such drugs which are being started for patients. At the starting time, a baseline fasting lipid profile should be done. And it can also be done in scenarios like when the patient has another fasting sample to be taken, like diabetic patient coming for a fasting blood glucose, it can be done. So in such scenarios, we can go for fasting sample. Otherwise, in most patients, like if non-fasting sample can be done, like initial lipid profile testing in any patient for cardiovascular risk assessment, patients admitted with acute coronary syndrome, before loading the statin, we can go for a non-fasting lipid profile. In children and elderly, it will be more beneficial because they will find it difficult to remain fasting for a long period of time. In diabetic patients also, it would be a good option. Patients on stable drug therapy also, to ensure compliance of the patient, we can go for a non-fasting sample. So the fasting or non-fasting depends on the question asked. So especially in patients who have a genetic dyslipidemic syndrome or patients with premature atherosclerotic cardiovascular disease, when assessing the risk, we can go for a fasting sample. And in conditions associated with the pancreatitis and hypertriglyceridemia, we can go for a fasting sample. Otherwise, for diagnosis of metabolic syndrome and in estimating the initial risk in an untreated primary prevention patient, in all these scenarios, non-fasting samples should be acceptable. So to conclude, the non-fasting and fasting measurements of the lipid profile must be viewed as complementary and not mutually exclusive. One will not replace the other. We cannot completely replace the fasting measurement in all the patients. There are some scenarios in which we need to go for a non-fasting sample, especially in patients in whom we expect abnormalities of triglyceride. We have discussed the scenarios previously. Common sense must prevail and a distinction must be made between their use in screening, assessment, and diagnosis. So we have to decide whether to go for a fasting or a non-fasting sample. So the main practical use of this would be that somebody coming for an assessment for the first time to our clinic today, even if it is a diabetic patient, we need not ask them to come for another day for a fasting sample. We can do the initial assessment with a non-fasting sample. But in some subsequent visits, we can ask them to go, even if required, we can ask them to go for a fasting sample if we are expecting something like a genetic genetic cause of hyperlipidemia in special scenarios, or patient having high triglyceride levels. In such a scenario, we can ask them to go for a fasting sample. Otherwise, patients without hypertriglyceridemia, without a genetic component of the dyslipidemic syndromes, in such scenario, patient on chronic drug therapy, initial assessment, the initial patient coming with an acute coronary syndrome, in all such scenarios, we can go for a non-fasting sample, and that would be enough in most of the scenarios. So fasting is less critical for first stage screening, but may be more important when trying to establish a phenotypical diagnosis of genetically determined dyslipidemias. And the one important circumstance where it would be especially useful, it would be in the setting in which the drugs are started, which can cause severe hypertriglyceridemia. So that was my presentation. So the question asked was whether to go for fasting or non-fasting when a lipid profile has to be taken. And then, so the answer would be that the scenarios that we have discussed now, in the certain special scenarios, we need to go for non-fasting sample, fasting sample. Otherwise, in most of the routine clinical scenarios that we are facing, a non-fasting lipid profile sample should be enough. Thank you.
So thank you, Dr. Thank you, Dr. Tushant, for that excellent clarification, because most of our patients will be in weak relief now. So now the topic is for discussion now. The session is for discussion now.
I think I will just start off with a question for Dr. Tejas. Dr. Tejas, are you there?
Yeah, I'm there.
I have one question for you. So it's a common question which the patients ask when they have self-monitoring of blood pressure. That is, if somebody does frequent blood pressure monitoring and they find that suddenly their blood pressure goes high, what is the advice that you give? Whether you ask them to titrate their anti-hypertensive therapy, or you ask for repeat measurement, or you ask them to come to the clinic. So what is your usual advice to them?
So I couldn't hear you very clearly, but I think you asked that at frequently monitoring at home, and if you find the readings are coming high, is what you are saying?
Yeah. What would be your advice to the patients if they find unexpectedly high BP readings in between?
So again, as the guidelines say, and as we say, that we don't rely on one single reading. You tell them to monitor frequently, morning, evening, twice a day, and for a minimum of 4 days is what is asked for. And if readings are persistently more than 130/85, then it is considered to be uncontrolled, if according to guidelines for home monitoring. So practically, if they are already on antihypertensive drugs, and if they are known cases of hypertension and on drugs, and if they find their readings coming persistently, say 2 or 3 readings high, then yes, then we tell them to up titrate the dose.
Thank you.
I think there is a question to Dr. Tushant. The question is like this: will using direct LDL measurements obviate the use of fasting lipid profile?
Yeah, actually that is an interesting point, because if you have to apply the threefold equation, many times we will rely on the triglyceride concentration, which would be dependent on the postprandial states, or some amount of variations can occur in the calculation of LDL cholesterol there. So if you are going for a direct LDL concentration measurement, that can in many ways take away the effect of postprandial triglyceride levels on the absolute LDL values that we are getting. So when we are going for a direct LDL concentration, that can in many ways take away the need for the lipid profile calculation of using the fluid wall formulation. But there have been some criticisms of that also, because in some of the articles, what they describe is that one is the direct LDL concentration assessment, the machinery or the equipments for that is not that much standardized, because these are the direct LDL concentration. The lab assays have come maybe in the last one decade, like around last 5 or 10 or maybe 15 years it is there. So those assays are not that much standardized as compared to the values that we get in a direct lipid profile assessment. So that is one criticism which has come up. And the other criticism which has come up is that when we calculate the LDL cholesterol based on the Friedewald equation, actually we would be calculating the sum amount of the apolipoprotein B also along with that, which actually is a marker of the atherosclerotic potential of the patient. Whereas when we go for the direct LDL concentration in the direct LDL assays, we are not assessing that part of the lipid profile. That lipid component is not taken into the picture. So these are some of the criticisms which have come up. So the practicality of that we will have to discuss, I think. But the criticisms that I have told have come up against the direct LDL assessment. But to a very large extent, direct LDL assessments can take away the errors which can occur in the Friedewald equation. That is true. That is there.
Thank you.
I think I will have one last question to Dr. Suresh. Suresh sir, are you there? Suresh sir? I think he's muted.
I think if there are no more questions, I think Chayas, you can.
Yeah. I think we can close the session. Yeah.
So,
Dr. Sugesh, you can conclude.
Thank you, Chairperson, and thank you all the speakers for conducting this session smoothly. We have come to the end of day 1 of Diabetes Digital Dialogue. We are extremely thankful to you for logging in and sparing your time. So this is the new normal. We are moving ahead with the new normal. And I wish you all a good night and hope to see you tomorrow morning at 9 a.m. for the second day of Diabetes Digital Dialogues 2020. Once again, thanks to the chairs, thanks to the speakers, and also extending our thanks to our sponsors for helping us conduct this CME smoothly. Thank you and good night.
Thank you. Thank you.
Good night. Thank you.
മഞ്ജു നമുക്ക് ക്ലോസ് ചെയ്യാന്ന് തോന്നുന്നു അല്ലേ? ആരും ഇല്ല ഇപ്പൊ വേറെ. ഡോക്ടർ സുരേഷ് എനിക്ക് തോന്നുന്ന ഇങ്ങനെ ഓൺ ചെയ്തിട്ട് പോയാന്ന്. ക്ലോസ് ചെയ്യണം. ഓക്കെ.
ഹലോ, ലാസ്റ്റ് സ്ലൈഡ് ഇട്ടില്ലായിരുന്നോ? നാളത്തെ ടൈമിംഗ് വരുന്ന സ്ലൈഡ്
അല്ല, അതിന്റെ സ്ലൈഡ് അല്ല മറ്റടുത്തേ ഇടുള്ളൂ. മറ്റേ
അയച്ചു കൊടുത്തിരുന്നല്ലോ ക്രിസ്റ്റീനയ്ക്ക്.
അത് ഇവിടെ അല്ല, കോൺഫറൻസിന്റെ അവിടെ ഇടും. കോൺഫറൻസിന്റെ അവിടെ ഇടും, ഇവിടെ അല്ല. ഓക്കെ, ക്ലോസ് ചെയ്യാം കേട്ടോ. ഓക്കെ,
ക്ലോസ് ചെയ്യട്ടെ? ക്ലോസ് ചെയ്യാം. ഇനിയിപ്പോ ക്ലോസ് ചെയ്യാം.
ഓക്കെ. മറ്റേ അവിടെ ഇട്ടേക്കാം, സ്ലൈഡ് അവിടെ ഇടാം. അവിടെയല്ലേ ആൾക്കാർ.
ഓക്കെ, ശരി.